hopefully everybody can hear me. It's top of the hour right now. For some of us, it's bottom of the hour because we've been up all night watching a very intense election. But we're going to probably give it about 5 minutes or so. Alicia, does that make sense? Just before we get started. Okay, I think you're on mute, but
I'm going to put some of those Zoom instructions in the chat right now.
Okay, excellent. So just before we get started, if everyone can make sure they read the chat, Alicia has put in just some comments around, aspects of this symposium, including what to do with cameras, how to speak, how to ask questions, etc. So just take a few seconds to quickly orient yourself to that. Just maybe another minute or so, and then we can get started. Just a quick little mention that we will be recording this symposium. So for those who are going to be in and out, you'll be able to have access to it, and certainly let people know who might want to have access to it later. Okay, so I think we can get started. So I'll start by saying welcome to everyone to what we can call the first, but hopefully not the last, unless it signifies the end of the pandemic and we're all together and being able to meet face-to-face, CNTN Virtual Symposium. I'm really excited to hear from what I would characterize as 4 very energetic and engaging speakers that are well known, I would say, both nationally and internationally. I'm hoping for a really engaging interactive session today. I'd like to emphasize that one of the biggest values of the CNTN is the ability for us to really engage with our patient partners, who can provide us really with new insights, angles, and approaches to the design and ultimately implementation of clinical trials and clinical research. I do want to remind everyone, though, that patient partners are present and that we should use accessible language. And of course, we should always be respectful, as I would say we all most certainly are. Now, I would like to start by introducing very quickly Hans. I've had the absolute pleasure of working with Hans Seems like across a variety of different things, but perhaps most relevant to this, the CNTN. Hans Vorster is from London, Ontario. He was diagnosed with FSGS over 20 years ago and eventually received a kidney transplant. His lived experience led to his involvement in several organizations, including the Ontario Renal Network, the Canadian Donation and Transplantation Research Program, and we actually had a very engaging meeting in that not that long ago. Several groups within CanSolve CKD, and he's been a member of the CNTN Capacity Building Committee, and myself and Hans have worked together co-leading the CNTN Scientific Operations and Executive Committees. And I'd say it's been just an absolute pleasure to work with Hans. Next slide. Before we start, I would like to just briefly introduce Mary Bocage. Mary will be giving us the land acknowledgement today. Mary is from Nipissing First Nation outside of North Bay, Ontario. She was diagnosed with end-stage kidney disease in June of 2013 and received a live donor transplant from her cousin in March of 2015. She's the vice chair of the Ontario Renal Network Patient Family Advocacy Committee and co-chair of the CanSolve CKD Patient Governance Circle, in addition to being a member of the CNTN Communications and Engagement Committee. Go ahead, Mary.
Thanks, Karthik. At this time, I would like to begin by acknowledging that the CanSolve CKD Vancouver headquarters is located on the traditional unceded territory of the Coast Salish peoples, home of the Musqueam, Tsleil-Waututh, and Squamish First Nations. I also acknowledge that where I reside is part of the Robinson-Huron Treaty of 1850. This is the traditional territory of the Anishinaabe people, specifically Nipissing First Nation. It is a trade junction connecting 4 directions that predates European contact. I would also like to acknowledge the traditional lands that each of you are joining us from today. Since it is Treaty Week here in Ontario, my challenge to you is to find out what treaty territory you live on. Why is that significant? Take those teachings and use them to help you foster your relationships to the land and the Indigenous peoples in your area. This is a step towards reconciliation and allyship. We are all treaty people. Miigwech.
Thank you, Mary. So before we dive right in, I just very briefly wanted to talk a little bit about how we kind of got to this point. I think it's pretty clear that March was one of the most difficult time periods for, I'd say, all of us, but especially our patients and our patient partners. And it was right around this time that from the CNTN perspective, we became aware that the CSN was going to be canceled. And we were faced with the dilemma of not being able to have a face-to-face CNTN meeting, something that we had really been preparing for. We thought about the prospect of moving the CNTN to the ASN meeting. Unfortunately, ASN then was canceled and became a virtual meeting as well. And it was at this time that in a very short timeline, the executive committee met together, discussed the idea of a virtual meeting. And ultimately, in a period of, I would say, weeks, we're able to come up with what I would describe as an excellent agenda, great speakers, and ultimately have put together this virtual symposium. Hats off to Alicia, who has really been instrumental in making all of this happen. Hats off to all of the committees that have been involved. And of course, a special thanks to our speakers who, ultimately couldn't do this without our speakers today. And I'm really appreciative that they were able to help us put this together on such a short timeline. Next slide. So just very briefly, going over today's agenda, we're going to start with 2 speakers who are going to be reviewing some of their studies, their study ideas. The first is Sam Silver, the second is Banu Prasad, and I'll leave their introductions to Hans to do. We'll take a short break, and then we're going to hear from Dr. Walsh and Dr. Wald around some issues pertaining to recruitment challenges with multi-center trials. And then Hans is going to help close off this, what will be a very entertaining and engaging meeting. Next slide.
Up to me, I guess, is it? I want to thank Karthik for a blushingly great introduction, except for the fact that I'm not from London, although I lived in London, England for about 5 years as a youth, but I have never actually lived in London, Ontario. I live in Kingston, which is the also known as the Cataraqui region in the traditional home of the Haudenosaunee, Wendat Huron, and Onondaga peoples. Anyway, it is my great pleasure today to introduce the speakers and take care of the post-speaker Q&As that will come along. And I'd like to start with the introduction to the our first speaker, Dr. Sam Silver. Dr. Silver is an assistant professor in the Division of Nephrology at Queen's University, just down the road here. His research focuses on the delivery of care for patients with acute kidney injury, both during the inpatient and outpatient setting. Dr. Silver, please. Sam, you there? Well,
I've lost Sam.
I think Sam might have dropped off the call there.
did he send us, leave us a chat? Did he say he was suddenly called out?
No. Maybe we can just flip things around, and since I know that I can see Banu, we can just advance and go to him, and if Sam comes back, we'll just backtrack and get back to him.
Well, Sam looks like he's connecting back there.
Oh, okay.
Let's give him a few minutes. Yeah.
Okay.
Am I back?
You're back.
Yeah, sorry about that.
You have been introduced.
Okay, no problem. Thank you.
You didn't hear my wonderful introduction of you, but you'll...
Okay, thanks everyone. Thanks for the opportunity to present our study and get feedback today. I decided to present this from home thinking the internet would be more stable, but it sounds like that was not the case. So I'm tethering from my phone now, so if hopefully I won't cut out again. And so this is our study promoting kidney recovery after acute kidney injury receiving dialysis. Next slide, please, Amanda. And these are my disclosures. I'll point out the third one that I have received some honorarium from Baxter speaking about the outcomes of in patients with AKI receiving dialysis. Next slide, please. And this is the clinical scenario that's motivated this work. This is a 74-year-old patient with sepsis. So it's a bad infection that can cause acute kidney injury or rapid decline in kidney function. The patient had a prior myocardial infarction and relatively normal kidney function to begin with, and was hospitalized for a week, including in the intensive care unit, and discharged on intermittent hemodialysis. And I was asked to assess his dry weight on dialysis rounds one weekend, about a month after the patient's already been on outpatient dialysis. And this is the question he asked me. Thanks, Amanda. Is there anything you or I can do to help the kidneys recover? Next slide. And this is an important question because we're seeing from data, including this recent data from Dr. Wald and Dr. Bagshaw from the START-AKI trial, that more dialysis is not necessarily better. In the dark blue solid line there, you see patients in the accelerated dialysis arm of the START-AKI trial. And in the solid red line, there are patients in the standard group. And almost all the patients in the accelerated group got dialysis. Not everyone in the standard group did. And so less dialysis in the standard group, more dialysis in the accelerated group. And more dialysis led to more hypotension in the accelerated group and more dialysis dependence at 90 days amongst survivors. Next slide, please. And we don't really know how this would apply to patients with acute kidney injury who are already on dialysis. Most of the studies looking at acute kidney injury have focused on when patients are first placed on dialysis in the ICU, looking at different dialysis modalities, different dialysis dose, different dialysis timing. But very few, almost no studies have looked at that population already on dialysis for a period of time, especially those still on dialysis on the hospital ward and those in the outpatient unit. And as you can see from this graphic, a large proportion will recover kidney function over time, but also a large proportion, close to half, will be left with new or worsening chronic kidney disease. Next slide, please. And this knowledge gap in how to dialyze this population who may be on their way or have a chance at kidney recovery leads to a lot of variation in care. This is a survey study done by some colleagues in the US surveying the American Society of Nephrology. And these are comments from healthcare providers on how they care for this population. Providers saying it isn't much different in terms of a normal hemodialysis script, so similar to patients with end-stage kidney disease. Some providers will look a little bit closer at the serum creatinine and urine output for evidence of recovery. And then the last point, thanks Amanda, some providers might even dialyze these patients differently, minimizing ultrafiltration, not challenging the dry weight, and using some diuretics. Next slide, please. So this variation in care and this practice of perhaps dialyzing patients with acute kidney injury soon after they're started, similar to patients with end-stage kidney disease, might prevent these patients from potential opportunities to promote recovery and recognize when recovery has occurred. And this slide just shows some potential strategies to promote and recognize recovery. The obvious ones being at the top and the bottom. But there are, based on some observational data, some dialysis strategies to minimize intradialytic hypotension and dialysis-induced ischemia that I've listed there. Some of these might be hard to implement over the long term, like the ultrafiltration rate. Others you might not want to do long term, such as using a high dialysate sodium because of risk of volume overload. But perhaps in the short term, in this population of patients who could recover kidney function, dialyzing patients using a more tailored strategy for that 3 to 6 month window when recovery could occur could be beneficial. Next slide, please. So in light of that, we've developed a study to determine whether a randomized trial of a standardized dialysis strategy versus usual care in patients with acute kidney injury who remain on dialysis is feasible. And our hypotheses are that we will be able to recruit or randomize 50% of eligible patients, and that over 80% of randomized patients will remain in the study and on the allocated study treatment, which I'll discuss about in the next few slides. And we plan on doing this for a 6-month study period, because after that 6-month period of time, recovery after acute kidney injury, the recovery to get off dialysis becomes much less likely. Next slide. So this is a graphical or visual representation of the study, which I'll talk about in more detail over the next few slides. In short, we intend to target patients who have received at least 1 session of intermittent hemodialysis and are off pressors and have been on dialysis for at least 7 days. For the feasibility study, we're looking to recruit 100 patients and we'll then randomize them to this bundle, AKI dialysis bundle of care, which I'll talk about in the next couple slides, or usual care. And we'll follow them weekly, including weekly blood work and urine collection to assess for dialysis discontinuation. Next slide, please. So the inclusion criteria are adult patients with AKI receiving dialysis. That's that acronym AKID. Sorry about all these acronyms. And we're going to include both inpatients and outpatients, including patients in the ICU who've been on dialysis for at least 7 days. We want the AKID to be due to presumed acute tubular necrosis, which is usually AKI due to hypotension or an infection. We want them to meet certain criteria for acute kidney injury. They need to have tolerated at least 1 intermittent hemodialysis session, and their oxygen requirements cannot be too great. The exclusion criteria are, we don't want patients who've been on dialysis for over 90 days where recovery becomes much less likely. We're excluding patients who have a strong suspicion for obstruction, glomerulonephritis, vasculitis, thrombotic microangiopathy, myeloma, or acute interstitial nephritis who would need a specific treatment for their kidney disease. We don't want any, we're excluding patients who've received any dialysis in the previous 2 months, recent kidney transplant, those with severe chronic kidney disease at baseline with an eGFR below 15, and those currently on pressors or mechanical ventilation. Next slide, please. So those who meet the criteria will be randomized to this AKI receiving dialysis bundle that we've coined safe dialysis and structured discontinuation, S squared, D squared. And we envision it as an order set where patients would get points in order to measure adherence, it would be a point-based system to determine how well in this feasibility study patients are the dialysis procedures and healthcare providers are adhering to the bundle. So the bundle consists of those elements I showed earlier that help minimize dialysis-induced ischemia. Things like cool dialysate, a high dialysate sodium, high dialysate calcium, at least a trial of loop diuretics if ultrafiltration is ordered, and then a maximum ultrafiltration of no more than 10 milliliters per kilogram per hour. Next, and the other key component is structured discontinuation so that opportunities to recognize recovery are not missed. And here and I would like some feedback on this from especially the patients in terms of feasibility at the end of the talk. We envision doing weekly 44-hour creatinine clearances that will be fed back to the provider with strict guidance on when dialysis should be discontinued. Dialysis should be stopped if the creatinine clearance is over 20, continued if it's under 12, and then in that gray area, dialysis would only be continued if there is one of these indications. Next slide. In the usual care group, the decision to initiate and prescribe dialysis would be totally up to the primary nephrologist, and decisions on discontinuation would not be guided by creatinine clearance measurements or the 44-hour urines, because that's the current standard of care. These are the study procedures, some of which we've covered already. The key point is the weekly 44-hour timed urine collections to assess for discontinuation in standard fashion, as well as weekly audits of dialysis prescriptions in both groups to look at both adherence to the S squared, D squared dialysis, as well as potentially any contamination between the two groups, potentially patients in the usual care group. If their nephrologist is hearing about this option, such as you are today, perhaps they'll start adopting some of these procedures, and that would affect separation of the two groups. Next slide, please. For the feasibility study, we'd be focusing on these outcomes: the proportion of eligible patients who consent to participate, and the proportion of patients who were able to follow to 6 months after their first in-hospital dialysis session. For protocol adherence, we envision weekly a score based on the order set, which is out of 6 points, and we'd accumulate a weekly score for each patient while they're on dialysis over the course of the study. And we'd want to see that we're on a cumulative manner in all the patients on dialysis in the S squared, 2 squared group, that the total point score is at least over 75%. The other way that we've thought of doing this is just looking at the last dialysis session each week instead of all the dialysis sessions in a given week. So I'd be interested to get some feedback on monitoring adherence to the S squared, D squared protocol. And then we'd also look at adherence to each component, because maybe if there's one component that's hard to implement, we don't use that going forward. Next slide. And in terms, if the feasibility study is successful, we'd be looking at more definitive patient outcomes such as these. So the idea being that in S squared, D squared, patients would get less dialysis. So we'd look at number of days that a patient did not need dialysis between the two groups, so-called dialysis-free days. Hopefully that would also result in less intradialytic hypotensive episodes on dialysis, similar to what was seen in START-AKI. And then we'd look at time to dialysis independence, days outside the ICU and hospital, and then a major adverse kidney events, which is a composite of death, chronic dialysis, and chronic kidney disease progression. We'd also look for potential adverse events to the S-squared, D-squared dialysis, such as potentially an arrhythmia from the different electrolyte compositions, or the need to institute emergent dialysis from potentially early discontinuation. And so we don't want to forget what's motivated us to do this study. This patient I was rounding on the weekend. Next point, Amanda. Who, when I was rounding on him after he'd been on dialysis for a month, he told me that, and his nurses reported that he was 1 kilogram below his dry weight. And looking back, he'd had several episodes of intradialytic hypotension over that month. And he reported that his urine output had been increasing for a while, and he hadn't had any labs since discharge. And we found his creatinine that day was around 250. So probably didn't need any more dialysis, which we stopped. 2 years later, he's left with an eGFR of 35. It's not terrible, but if you compare it to what his baseline kidney function was at 67 before all this happened, you wonder how much the additional sessions of dialysis and the episodes of intradialytic hypertension that he didn't need led to this degree of chronic kidney disease. Next slide. So we've seen in patients like this who remain on dialysis, they can be treated similarly to patients on long-term dialysis, and that this could lead to missed opportunities to promote kidney recovery and recognize that dialysis can be discontinued. We envision the S-squared, D-squared intervention, which comprises easy to apply, inexpensive maneuvers aimed at minimizing dialysis-induced ischemia while emphasizing timely dialysis discontinuation, could help this population. And this will be one of the first interventional trials focusing on recovery in this patient population who's been on dialysis for a period of time. And it's the initial step to helping build this evidence base for this understudied population. Next slide. And so I'd like to thank my collaborators and co-investigators, as well as Crescent, who has supported me as a new investigator through salary support, Canadian Society of Nephrology, NCIHR, and as well as the Kidney Foundation through their Crescent support, as well as an operating grant to help support this study. This is my contact information, and then I have a list of questions here on the last slide that I'll just go over quickly, but I welcome any other comments, even if they're not included here. So these are some questions our team had. Is in-hospital mortality too high for inclusion of patients in the ICU? So a large proportion of that population in the ICU will die related to an infection, not necessarily due to their kidney disease. Now we are targeting patients not on pressors, not on mechanical ventilation. We'll reduce that a bit, but we wonder if that will make recruitment less efficient. Next question is how to minimize contamination between the two groups. It's an open label study, so it's not blinded. So this is to avoid patients in the usual care group receiving some components of the S-squared, D-squared intervention. Is there a better way to measure S-squared, D-squared adherence in the order set and point system we envision? How frequently should and are patients willing to complete the 44-hour urine collections? Is weekly too much? Is weekly okay initially, but then should be backed off after a month? The other thought we had is doing 6-hour time collections, which might be more feasible and accessible, and that was done in the VA ATN dialysis study, although there's less evidence supporting that approach, but it might be more feasible and acceptable. Any patient-reported outcomes of interest, and then any methodological concerns, realizing that the time from dialysis initiation to recruitment could vary based on our criteria from 7 to 89 days, meaning we'll have patients in the study who've been on dialysis for 10 days and some patients who could have been on dialysis for 80 days, but by the time they get transitioned to intermittent dialysis and are eligible. And that will be balanced by randomization. And we'd address that in the design, but we wanted to raise that to make it explicit. So I welcome any comments on this or any other questions or comments from the group today. Thank you.
Rita has her hand raised. And otherwise, if anybody wants to put a comment in, you can put a comment in the chat and I'll let Sam know. Rita?
Hi, Sam. That was a very nice presentation and a very important question. One response to the questions you have, or my thoughts on one of the questions you have, and one question from me. So number one, with respect to the in-hospital mortality, I'm wondering, given that your question is really whether or not we're doing harm by prolonging dialysis or doing dialysis wrong in some way in patients who have acute kidney injury, aren't you really interested in those patients who require prolonged dialysis after their initial episode? So what about randomizing patients after, say, 3 weeks or something like that, that they're still on dialysis and they're still alive, and that would get rid of your bias with the hospital mortality potentially? Then the second comment I had is, what are you going to do with patients' blood pressure medications? Because I often find in the hospital that we're often having major debates with the cardiologists after they leave the ICU and other specialties as well, with respect to, okay, well, they need the beta blocker, et cetera, to protect the heart. And we're saying, well, no, we can't dialyze them. Intradialytic hypotension is bad for the heart. And so there's constant push and pull back and forth. So I'm wondering if you have any thoughts regarding that.
Yeah, so to answer your first question about the duration, I think it's a good point. We're trying to balance recruitment numbers versus and catching patients during that period of stability and sensitive time when they could recover. So that's why we picked the time frame that we did. But certainly, we've been back and forth on the time frame a bit. And then your comment about the blood pressure medications. So we haven't built that into the bundle as of yet. I guess our thought would be that there's as you were saying, the cardiologists do have a lot of strong opinions on it, as do other services, so may not necessarily be under the direct control of nephrology, which is why we've left it out. But yeah, it's definitely something that we should think about going forward. Thank you for bringing that up. There's a question, I think this is maybe from Karthik in the chat. Sorry, I'm not sure if Rita had a follow-up or not.
Well, I guess with respect to, I understand the practicalities with respect to the blood pressure issue, but I guess at the end of the day, you may actually not be able, even if your bundle is actually the right thing to do in terms of improving how patients do, it may end up being not beneficial if, for example, the patients are always hypotensive because they're on too many blood pressure medications. So I don't think that ignoring it is probably going to work for you, but that's my own personal opinion.
No, thank you for that. We're definitely, we haven't thought about that too much, so we'll definitely take a closer look at that going forward. Should I go to, is it okay if I go to the questions in the chat?
Then we'll go in the
So
chat.
there's a question, I think, from Karthik, saying, I believe there are ways to measure residual kidney clearance that may be shorter duration. Did you consider? So we initially had 6-hour time clearances. There's actually very little, and if there's anyone with more experience in measuring creatinine clearance for patient on dialysis, please weigh in. But when we talked with people and researched the evidence on this, 44-hour creatinine clearances seem to have the most support and most data behind them, although limited. Certainly we could try, we initially had 6-hour time collections in there, but switched to 44-hour. But we definitely agree that 6-hour would be probably more feasible and attractive.
Anu has a question.
Sam, that was a great talk. I just, is it possible to see in your intervention arm if you could decrease the frequency of dialysis? Sometimes non-oliguric AKI patients really do not require the 3 times a week hemodialysis, and I suspect sometimes offering them more frequent dialysis is actually doing them more harm. But they're discharged from the hospital with a standard prescription of 4 hours, 3 times a week. Would that be something that you'd be considering?
Yes, thank you, Banu, for bringing it up. So that's something we've talked about quite a bit, and that we're trying to incorporate into the structured discontinuation. The idea would be if a patient is in that gray clearance area of 12 to 20, they would have to have one of those absolute indications to dialyze them. But we would build in that patient in that 12 to 20 range coming back for another assessment for dialysis during a period of time, where if they met that indication, they would be dialyzed again. And then perhaps that would lead to a patient getting less dialysis, like twice a week, like you mentioned. And we thought that would be a better way at getting at reducing the dialysis frequency, which we agree is an important component, instead of building in mandating a twice a week option. That's how we kind of have built it in. But we've done a lot of, and still probably have a little bit more thinking to do about that, because it's come up quite a bit. And then there's a question in the chat from Michael Walsh asking about surprise clearance is such a prominent component. In my experience, stopping dialysis is 90% about volume, and uremia clearance is rarely limiting. So it is both. And that's why in the protocol, or in most prior studies that have looked at discontinuation, usually there's a urine volume trigger, and which can be like usually is a urine volume around 500 milliliters per 24 hours or a liter per 24 hours. And then even in structured algorithms that have used that, the two main reasons why patients are still continued on dialysis, even if they're making a lot of urine, are either clearance or volume, kind of split 50-50 in these structured protocols. Our thought is that based on the creatinine clearance, if you're above a 20, you certainly don't need dialysis. And if you're in that gray area of 12 to 20 and the breathing is stable, we thought there would be enough urine output at that point to justify not dialyzing the patient. We have talked about adding in a volume component into the structured discontinuation, such as saying the urine output must be more than 500 milliliters per 24 hours and a clearance requirement. The downside being, I guess theoretically, you could get into a situation where someone has a creatinine clearance over 20, but urine output's low, and you probably wouldn't want to dialyze that patient. So we've left it with the creatinine clearance because we think that will probably cover the volume component as well.
Any other responses to that? We have a question from Yimin Liu for you. What about furosemide tests? Would that be included in the evaluation to stop dialysis?
So I think that's a good question. For those who aren't familiar with the furosemide stress test, it's a way of giving patients with AKI a large dose of furosemide to see if they pee or not. And those who pee have a better outcome than those who do not. It hasn't really been studied in our patient population that we're targeting, those who have been on dialysis for a period of time. It's really only been studied in patients with severe AKI to decide if they're going to progress to dialysis or not. So for that reason, we haven't incorporated it into this protocol. I see a question here from Nancy Verdun. Has low and slow dialysis been considered with frequency determined by blood work? So we haven't talked too much about low and slow dialysis. So I guess this thought would be like SLED, like parameters, like over a period of 6 to 8 hours. So we haven't thought about that yet in the protocol. I guess it might be from an implementation point of view, maybe harder to do in an outpatient unit, but it's certainly something that we could look at going forward. And there's another question about interdialytic weight gain. I find this is often a good indication of recovery. Yes, interdialytic weight gain is certainly important when a physician's making an assessment to decide on recovery, although we found it difficult to kind of standardize exactly what that would be in a feasible fashion, which is why it's not currently included. And then Banu is asking, can we have a third arm where patients are placed on PD and see if that's more kidney friendly? I think that's a great idea. I think then you get into, and maybe some of the patients can comment on that, then you get into a challenge of, I guess, recruitment where, that decision on intermittent hemo and PD can be a very personal one. And that's one of the reasons it's been difficult to recruit patients to a randomized trial looking at that question in the chronic dialysis population. So I think it might be similarly difficult in this population as well, but it would certainly be an interesting question or intervention to answer. And then Karthik asks, if properly resourced, you could address contamination by cohorting on dialysis shifts. That's an interesting point. So that's definitely something we should consider, but yes, I agree. It might have some feasibility issues.
Any other questions? We've got a couple more minutes. No? Well, I thank Sam for making my job easy. If there are no more questions, we'll move on to the next speaker. Thanks, Sam. Well, thank you, Sam Silver. Our next speaker is Dr. Banu Prasad, a consultant nephrologist in Regina and a clinical associate professor of medicine at the University of Saskatchewan. His research interests include the use of renal denervation in loin pain hematuria, bone health in CKD, and home dialysis. I turn it over to you, Dr. Banu Prasad. You're on mute.
Can everybody hear me?
Yep.
Okay, so I'd like to thank CNTN for allowing me to share our presentation on this feasibility study, and we can share it with trialists and peers and patient partners. So this is a feasibility study of a randomized control trial investigating denervation in patients with loin pain hematuria syndrome. Next slide, please. So what exactly is loin pain hematuria? And to put simply, this is pain and hematuria arising from the kidney with no obvious identifiable cause. It's unfortunate that these patients are initially seen by urologists in multiple jurisdictions where they undergo a cystoscopy followed by a CAT scan and eventually are sent back to their family doctors. And by the time they come back to into the hospital system, they're often on very heavy doses of opiates, and few of them we've seen are on spinal cord stimulators. Pain is the main reason why these people seek attention. And, we've often seen that pain leads to increased absenteeism, it fragments interpersonal relationships, it leads to mood disorders, and they are severely, severely impacted when it comes to their quality of life. So it's pain relief that most of these patients are seeking at any given time. Next slide, please. So because it's pain, I'd like to spend a couple of minutes talking about the pain pathways. So the pain fibers start in unmyelinated alpha and Charlie fibers that go through the periarterial nerves into the renal nerves, and from there to the lower splanchnic nerves, and via that through the dorsal root ganglion and up through the spinothalamic tract. So pain relief has to somehow impact these fibers or the relay or the transmission of these fibers. Even in places where there is multidisciplinary pain clinics, pain control in patients with LPHS has been a disaster. Even when they use opiates or non-opiates or a combination of antidepressants, muscle relaxants, and so on, pain control has been quite poor. And so, next slide, please. And so urologists have come across, innovative ways of interrupting these pain pathways. And as you can see in the examples that were given here, examples such as rhizotomy, capsulectomy, and so on, has, you need operating room time, you need general anesthesia, you need post-op recovery time. And even with all of that, the pain relief is quite suboptimal. The only surgical intervention that has led to long-standing relief of pain is autotransplantation, where you actually remove the kidney from its current position and then transplant it at an alternative site, whereby taking away the pain pathways to the kidney. So it was very clear for people looking at pain relief for LPHS that a more simpler and easier way of pain relief had to be identified. Next slide, please. So next, please. So whether there is, whether the pain pathways are, afferent or efferent, they join together in the adventitia of the renal artery. So both of the afferent and efferent nerve pathways are actually in the adventitia. So it allows us, next slide, please. It allows us to selectively target these little pathways by delivery of denervation through catheter-based techniques. So this is, initially it came out in 2009 for interrupting sympathetic nerve pathways for treatment of hypertension. And now we are expanding its use for treatment of loin pain hematuria syndrome. And you can see examples of the catheters on the left-hand side of your screen. Next slide, please. So this is minimally invasive. And as you can see on the right side of your screen, that introduction to the renal artery is gained through the femoral artery. And once it's in the renal artery, you can see that in this example, which shows a single electrode, once the electrode is opposed to or abutted to the endothelium of the blood vessel, it then releases energy. It's low power, it's focused delivery of radio frequency energy. And in that area where the energy is being released, we hope that that energy leads to destruction or disruption of the pain pathways. And when it was considered in its initial, in 2009, it was predominantly to interrupt sympathetic nerve pathways in the hope of bringing down the blood pressure. But it is realized now the sympathetic and the pain pathways join together and travel together. So its use has now been expanded to loin pain hematuria. In the older ways of doing things in 2009, 2010, in the initial studies, it was a single electrode, which the radiologist or the cardiologist at that time would then turn around in a circumferential manner and hope that they would deliver, and it was a hope that they would deliver energy to the entire length and also along the circumference of the renal artery. Next slide, please. So this is information that came after the failure of the initial hypertension studies. And on the top of the slide, you can see that every green dot represents about 10 nerves. So the proximal part of the renal artery, the nerves are quite widely distributed, and the distance between the lumen and the nerves differs quite significantly. And as you go to the middle of the renal artery and then go more to the distal parts of the renal artery, there is more convergence of the nerves towards the lumen, which allows people, allows interventionalists to target those nerves and disrupt those nerve pathways. So one of the reasons why initial hypertension studies failed was that only the proximal part of the renal artery was being targeted with a single catheter, which you can see on the left-hand side, which is the Medtronic first-generation catheter. And our own results with this in patients with CKD was quite equivalent. And that is one of the reasons was probably we were just not hitting enough nerves. Next slide, please. So for our second study that we used with our LPHS patients, we used the Boston Scientific catheter, which is right in the middle. This has got 6 electrodes in a circumferential manner. And we were, instead of giving just 4 ablations, which we were doing for hypertension study, we started to give up to 22 to 24 ablations in each kidney. and most of the ablations in the distal part of the blood vessels, and even in the branches of the renal blood vessels, so where the approximation of renal nerves to the endothelium is much more tighter. And our latest study, which we are going to do and which we're going to talk about, is going to use the Medtronic second generation catheter, which has got about 4 electrodes, again in a circumferential in a manner. And hopefully this time we are going to give up to 32 ablations as part of our study protocol. Next slide, please. So, and next slide again. So, so we hope that by giving 32 to 34 ablations, and even more if the patient has a short renal artery and they have multiple branches, we'll be attacking or tackling every single branch of the renal artery. If there are any accessory arteries that come from the kidney, then automatically they will also be, ablated. So we're hoping to get at least 32, and if possible, even more than 32 ablations to get. And we hope that by doing so, we would be able to get a near complete renal denervation, which hopefully will bring the pain levels down in this unfortunate group of people who are actually struggling with pain relief. Next slide, please. So as a center, we are quite well-versed with renal denervation. We've published on this in Loin pain, and as a case report, as a case series, and we also have experience with regards to its use in hypertension. And so we feel that we are well positioned to carry on the next level of investigation in patients with this particular problem. Next slide, please. This is data from what is still the largest case series of RDN in patients with LPHS from our group. And as you can see in this particular slide, that these patients had incredible amount of pain. So if you look, this median pain as per the McGill pain score was 38.5. But if you look at the range, it varied anywhere from 34.3 to 63.8. So it's with 78 being the maximum. And so if from that, the pain in 3 months came down to an average of 7.5, and frankly, 50% of patients were off opiates by 6 weeks, and the improvement persisted up to 6 months, with the pain score coming down to 2. And as you can see, there's some people with zero score and up to 18.5. I think this is important because before I knew anything about LPHS, I was quite worried about LPHS in that I felt that these were patients who were drug seekers and, saying that they had something which we couldn't see. And these results actually helped me change my view about these unfortunate group of patients. And as the pain improved, as you can see, depression improved. The depression score came down from 3 all the way to 1 in 6 months' time. And as the pain and depression improved, patients were less disabled, and they went from 43.5 to 13.5 in 3 months, and then all the way to 4.4. So we, in our case series, we had a lot of people who were going back to work and working as social workers, nurses, and radiographers, and so on. And it was truly liberating for us to see these individuals get back to their vocations. Next slide, please. And again, in this SF36 questionnaire, I can see that most, if not all, self-reported measures were heading in the right direction. And I would like you to point out to emotional role and mental health. And you can see again that emotional role improved from 33.2 all the way up to 100. Again, suggesting that these people were not crying for opiates. They really had a problem. And once that pain pathways were interrupted, there was automatic, there was improvement, not only in mood, but also in their quality of life. Next slide, please. So, so coming to the study itself, we are planning to do a feasibility study prior to a proper randomized controlled trial. This is a double-blinded, parallel group, partial crossover, sham controlled. in a single site here at the General Hospital. We chose 10 patients, and that's because the prevalence is quite low. It's supposedly at 0.13%, but I suspect it's a little bit higher than that. This is our first rodeo to do a RCT, and we wanted to have a patient group that we were comfortable with, that we could enroll and follow over 12 to 18 months. And then Medtronic, the company that was providing us with the catheters, requested that they wanted to see us perform at least 3 procedures under direct supervision so that a radiologist can be certified to go ahead with the study. Because it is such a rare condition, we then decided to add 3 more as a roll-in. Basically, they will undergo the procedure, it'll be supervised, they won't be randomized, but we will be collecting data on them over a period of time. And so the next 10 will be, after the first 3 roll-ins, the next 10 will be randomized into 5 in each arm. Next slide, please. The primary objectives of our feasibility study is to see if 80% of our patient can undergo the procedure within 6 months. So from the start time to within 6 months, if we can get 80%. If 80% of randomized participants remain in the trial and complete 6 months post their initial interaction with us. The secondary objectives were to see how many of them have eligible renal artery anatomy. So on CT scans, especially with contrast, there is a need that these patients need to have at least 3 millimeters of renal artery diameter. This is for the catheter to get lodged into the artery and deliver radiofrequency energy. So we have some idea, but sometimes we do see surprises where it does look that the artery is greater than 3 millimeters in diameter. Only when a formal angiogram happens that the size is a little bit, the diameter is a little lower. We also wanted to see the proportion of patients who are randomized to control group who crossed over after 6 months. So if they've done sham and they're undergoing GA, whether they want to come back for an RDN treatment. And also, looking at clinical outcomes, such as the potential for endothelial injury. Most people who speak to me about RDN are stunned and amazed to hear that we can give 24 ablations or 30 ablations and expect the renal artery to stay healthy. And they say, well, how is it possible? There has to be some degree of endothelial injury, even though we haven't seen it, but this is something that we would love to see in our study. Next slide, please. So the inclusion criteria is people above 18, diagnosis of LPHS by a nephrologist in consultation with a urologist who actually understands LPHS. And for that, we need to get a normal CAT scan, a triphasic CT scan with contrast, a MAC3, a normal MAC3 scan, and negative cystoscopy. For the purpose of this particular feasibility study, we are only accepting patients who are on opiates for LPHS treatment for greater than 3 months. We just wanted to get the more severe patients, and the renal diameter of 3 and 8, and that is based on the requirement to undergo this procedure. So the exclusion criteria are people who have undergone kidney auto transplant. It might be surprising to people who don't follow LPHS, but it does happen that even patients, when they're auto transplanted and have a kidney sitting in your pelvis, pain comes and it recurs after 10 to 12 years. And it possibly is due to new neural connections. And so we've had one person who was referred to us and we had to exclude at this point. We've had about 20 patients that have already undergone RDN for pain relief as part of different studies, and they will all be excluded from future studies. Estimated GFR less than 45 because of the potential for renal arterial damage, and the usual collection otherwise, like pregnancies and CPAP and so on. And if they've undergone angioplasty or stent, then there would be the access to the endothelium will be restricted, and hence we won't be able to perform the procedure. So these are standard exclusion criteria for RDN in any study. Next slide, please, Amanda. Thank you. So we'll be collecting information like age and sex, whether it's unilateral or bilateral pain, and comorbid conditions. Most people have comorbid pain in other territories, which could be, they often have pelvic pain or, and other kind of pains in other territories. And next slide, please, and next. And so, and we'll be looking at beta HCG because most patients that we look at are between 18 to 45 years of age, and they're in the childbearing age. So make sure that they're not pregnant. The outcomes, the outcomes that we're going to look at would be pain using two different scores in the basic data collection, quality of life using two different scores, self-reported disability using oscillatory, and then mood using CES depression scores. So, and then we're requesting our patients to keep a pain diary, which they can share with us, which will tell us about how much opiates they were using on a daily basis and what was the frequency of use, because there are times that the use goes up and they call them acute episodes. And so they all have a baseline pain, and then they have these episodes where they require more pain relief. And so we're requesting our patients to keep an eye and start documenting them. Next slide, please. So randomization will be done by the interventional radiology suite. We have made sure that there will be no cardiologist associated with this particular process. The randomization is going to be a web-based system, and we will be doing a 1:1 treatment allocation design. So 50% will have derivation and 50% will have sham. The ones who have sham, and this was a sticking point with our REB, was sham itself, because the moment you go into the renal artery or you puncture the femoral artery and go into the renal artery, the chances of risk go up. They were hoping that we would do a renal venogram of some sort, or just puncture the femoral vein and push them die or something like that. But we wanted to replicate the procedure as close to the real procedure as possible. And so after long back and forth between REB and ourselves, we were able to give them the necessary reassurance, and then the trial was allowed to proceed. RDN procedure itself would be a renal angiogram to look for the size or the diameter of the renal arteries, followed by the Simplicity spiral denervation system, which is the Medtronic catheter, which is what I showed you a little bit earlier, which has got 4 delivery points. Next slide, please. Yes. So the study subjects and ourselves will be unaware, which is the case in any double-blind study, and the interventional radiologist and his staff will be aware. So for the procedure itself, for the first 3 roll-ins, we'll all be going in to watch the procedure, and after that, we'll be keeping our safe distance from the study. Next slide, please. And data collection will happen at 6-week intervals, 3 and 6 months. And this is, and we'll be checking their frequency and number of pain medication use, using a daily pain diary, and obviously looking at the outcomes, which is pain, quality of life, mood, and disability, and lab data looking at creatinine, and a follow-up CT scan to look for the, how the endothelium was performing after the procedure. After 6 months, the patients will be unblinded, and participants in the sham arm will be offered the treatment group, and if they choose to do so, and if they're so, we'll try to get them in, and then the procedure will happen under general anesthesia. Both the sham and the real procedure will happen under GA, and then they will be followed up again for 6 months after that. Next slide, please. And this is pretty much, and I've talked about this in previous slides, but I just wanted to say that initial consent, then eligibility assessment, randomization, then into 2 different arms, and then outcome measures at 6 weeks, 3 and 6 months, and then follow up again for another 6 months after the crossover happens. Next slide, please. And I think this is information that I have probably shared at different time points, but again, pretty much giving you the same kind of information that the previous slide showed. And so eligibility, patient characteristics, labs will be at the baseline, and week 6, 3, and 6, we'll be looking at lab tests, patient questionnaires, and their pain records. Thank you. Next slide, please, Amanda. So our outcomes are going to be, we're going to look at the proportion of randomized participants who have completed the follow-up measures. So this is going to be our first outcome. The second outcome is to look at there's multiple, but the ones that we want to really focus on is whether it's feasible for asking these patients who have a life of their own to see whether they're able to maintain a pain diary. Because writing a diary on a daily basis is sometimes cumbersome. And, and if we look at number of people who actually take their antihypertensives or take their medications on time, it's tough enough to do that. And expecting people to keep a diary is likely to be difficult, and we recognize that. And that's one of our questions that we're going to ask in a feasibility study. And we're also going to look at the number of patients who completely cross over and follow up after 6 weeks to 6 months. Next slide, please. So statistical analysis will be we'll be comparing a baseline data with data at 3 weeks, 6 weeks, 3 months, and 6 months with these particular analysis. I think the analysis is pretty simple. Next slide, please. So this is all very exciting to us. We've done retrospective work. We've done different kinds of work in our program, looking at fractures, frailty, and so on. But this is new for us. So, so forming a steering committee, having a data safety monitoring board, and the manager of our kidney health center has kindly agreed to be the chair. So we have physician colleagues, researchers, statisticians, a part of the monitoring board, and a steering committee, including myself and the radiologist who's performing the procedure. We've got the necessary approval in place. We've got Health Canada authorization, and this is the NCT number that is documented on the left side. So next slide, please. So we are ready to start, the CJKD recently published our study protocol, and so it's on the website. And so we recently had a few conversations just when COVID is starting to roll in again in our province. We are starting to roll in 3 of our patients on November 16th. And if the institution doesn't close our studies, if the numbers do increase, then we are hoping that we would be able to randomize 1 to 2 patients for the first phase. And we hope that instead of waiting 6 months, we'll be able to complete our first phase within 6 weeks. And 6 months later, we hope that the sham patients who undergo the sham procedure will undergo the real procedure. So it's now mandatory in Regina and Saskatchewan to wear masks in any public space. So I think there's a little bit increased scrutiny. So we're a little nervous about how this is going to roll out because the numbers have started to increase in our cities. Next slide, please. So I would, suggestions and comments from trialists who are on this group chat about randomization, sham arm objectives and outcomes. It's important to remember that this is indeed a rare condition, but it's rare because we don't see it. Is it rare because urologists see it and we don't get to see them? And but actually when we go around talking to people about this, more and more patients start surfacing because people are just unable to connect the dots that what you're seeing in front of you is actually Loin pain hematuria syndrome. So next slide, please. So I'd like to thank the team with us, Mariam Jafari, who's been with me in the office now for a couple of years and has gained a lot of valuable experience for interacting with Ron Wald's team and Karthik's team for their studies. So that has been really helpful for us. Shelly Geibel, who was our rock solid support for all the studies that we've had over the years. And it's unfortunate that she's no longer working here, but but she had a great role to play in our previous RDN studies. Pratima and Michelle were research scientists that helped us with protocols and getting grants. Rita, on whom we relied very heavily on in the first 2 years when we were trying. We had a whole bunch of ideas, but there was a lot of Brownian motion in our head, and Rita helped us, put it all in a single file and channel our ideas in the right direction. And obviously Francisco and Kunal, the urologist and radiologist, and Medtronic and Ada, who's in Toronto, and Doug Hedrick, who's a VP, sits in Minneapolis, and they have all been actually very, very helpful for us to get through this project. And a special thanks to all the private donors who have come forward, friends, colleagues, who have realized that we've had some challenges with getting funding, and they've all helped in their own way to help us see through this feasibility study. So thank you so much, and I'll be open to questions.
So we have no chat, nothing on the chat room. Does anybody have a question from the floor? No, you sure?
Yeah. Hi. Can you hear me?
Yep.
My name is Austin. I was on dialysis for 4 years, 2016 to 2020. I had a transplant in March of 2020 this year, and very interesting, that presentation. The pain you talk of, I did experience that it's been 7 months since my transplant, and but fortunately, 7 months later, the pain was never as severe as you spoke. But I can understand how the pain can be a disability, because when I felt the pain initially, I didn't know what it was, because where the transplanted kidney was healing, and the area there was no feeling there whatsoever. It was just like dead tissue all around where the scar was. And slowly, everything started to come back to life. And it felt like there was pain going from my down that area to my left finger on my left arm. It was like it was going through. It was weird because it's gone now, like that pain, and it felt like I don't know, really, like the nerves were trying to reconnect. I really don't know, but it's funny that you talk about I'm scheduled to do a CT scan next week. So unfortunately, I wouldn't fit into your trial because I have 3 stents in my aorta. But I really know the pain that you have identified because I've experienced it, but it's gone now.
Well, thank you for your comments.
Thanks, Austin. There is a question on the chat from Yumin Liu, and perhaps he could ask it for himself.
So would it be feasible to keep the participant blind to the device during the gesture? I would suppose the intervention time, renogram plus denervation, would be much longer than those with sham procedure. And yes, Yumin, thanks for asking this. So if the individual is just going through a sham procedure, that's a quick 10-minute turnover. So the patients, we don't want to have to be under general anesthesia for long. So we'll certainly the general anesthesia. So we'll try to restrict the time, but they will be in the angio suite for about 45 minutes. So the time in the suite, it will be 45 minutes. And if the family is waiting in the medical diagnostic recovery room, they won't be seeing the family for at least 45 minutes. We hope, and in this way, we won't be taking too much of the radiology suite time, but keeping them in somewhere in the place. If that's the question, if I'm just not, so are you saying that people who go back sooner will know that they haven't had the full deal? If that's the question, they won't be going any sooner. They will be within the suite, but not necessarily on this, undergoing the procedure, if that makes sense.
Okay. The next question is from Tyrone Harrison.
I'll take that. It's okay. The question was what was the patient advisor's role? Was there any patient experiences included in your outcomes? Yes, one of the things that they asked, and it was also raised in the last CNTN meeting, was to why are we just recruiting patients who are on opiates, and why wait till the time they get onto opiates? And I think the request from patient advisors was that we should be doing this before they get onto opiates. And that's something that we will consider for our main study, for which we'll require 84 patients in 2 arms. But we really wanted to get, individuals who are actually quite struggling with the disease so that we can look at the difference between the 2 groups. The next question is from Karthik. How to expand the reach of this study, perhaps internationally. And yes, and I think the answer might come from our collaboration with Medtronic. Medtronic has partnerships in the hypertension field. So there are areas in different jurisdictions, and I can think about like Perth, for instance, Amsterdam, for instance. In the United Kingdom, it's Sheffield, for instance, ourselves. And so there's lots of places where, these are like little areas where denervation happens a lot, and people are they have lots of experience with denervation. So those would be the areas that we would be happy. And the only challenge will come with regards to funding. And that's where, and I hope with our experience with, large case series and doing a feasibility study, that funding opportunities open up in future. And the next question is Tyron Gordon Harrison asking about, I missed a description early in the presentation, but I wonder what proportion of patients with LPHS are on 3 months of opiates. And the answer is 100% of them. 100% of them are on, especially in the group that we have currently recruited for our 10. So they're all on opiates for close to 2 years at this point in time. Is silence a good thing?
Yeah, I think so. You've obviously answered the questions that were necessary to be answered. Is there anything else that anybody wants to talk about here? In that case, I suggest that we go on to the next item on the agenda, which I believe is a break. That's what it says here.
Hans, 1 second. Yeah. We're going to let Dr. Wald do his presentation before we have a break, only because he has to leave because he's on call. So sure. We're just going to switch around a little bit, and then we'll have a break, and then we'll let Mike lead the discussion. But first, we're going to let Mr. Wald and Dr. Wald and Amanda, can you stop sharing the screen so that there you go. Thank you.
Okay, I turn it over to the dynamic duo of Dr. Ron Wald and Dr. Michael Walsh.
Thank you.
Let's hear it.
Thank you, Hans. Does everyone see my slides? Are my slides up?
Yep.
Amazing. Okay. Thank you.
Not very readable. No, it's a large screen on a.
Not the presenter view.
Is that better? Oh, hold on, I'm gonna.
It's not showing presenter view. There you go.
Is that better? Okay, perfect. So thank you for inviting me and allowing me the opportunity to speak. A warm thanks in particular to the patient partners who are here. We look forward to hearing your feedback. I apologize again in advance for having to depart a bit early, but I do want to present the slides and leave the hard work to my friend Mike Walsh, and we'll debrief afterwards once we hear everybody's feedback. So this is an opportunity to present the phosphate trial. It's not the first time we've presented this trial at CNTN, but it's actually at this point in time, we're actually on the verge of launching it. So after many discussions, many meetings, a lot of great feedback from this group, we're actually almost ready to go. So I want to initiate the discussion with two scenarios. You have a 65-year-old man on end-stage kidney disease due to glomerulonephritis. He's on dialysis 3 times per week. Past medical history, other than his kidney disease, is remarkable for gout. He's listed for a transplant. His calcium's 2.2, his phosphate's 2.3, his PTH is 42. He feels generally well. He's receiving, as part of his phosphate binding regimen, 2.5 grams of elemental calcium per day. So probably about 5 tablets of calcium carbonate, about 7 or 8 tablets of Tums. Are you satisfied with this phosphate control? Is this phosphate okay, the 2.3? And if not, how would you modify therapy? Another scenario that I want to raise, a 46-year-old woman with end-stage kidney disease due to diabetes. Her past medical history is remarkable for coronary disease and hypertension. Calcium's 2.35, phosphate's 1.3, PTH is 60, so she has excellent phosphate control. She's receiving 3 grams of elemental calcium per day, so about 6 tablets of calcium carbonate or about 10 tablets of extra strength Tums, and 2,400 milligrams of Savelmer per day, so 1 tablet of Renagel with every meal. Lots of binders, lots of pills there. And, you know, she tells you on rounds, you know, that I'm not happy about the amount of pills I have to take, not just my phosphate binders, but everything. And, you know, do you convince her that the pills that she's taking, at least for her phosphate binding, are worth it? Because clearly they've achieved what many would consider optimal phosphate control. Is the pill burden that that she's had to be subjected to worth the benefit of a normal serum phosphate concentration? So I want to highlight, you know, in a few slides, I think I think all of us on this call, patients in particular, understand what they've been told for many years about the adverse effects of phosphate on the cardiovascular system and on mortality, actually. And the reason we're so obsessed with phosphate is because there have been many observational studies that have demonstrated a link between hyperphosphatemia, high serum phosphate levels, and adverse outcomes. This is a meta-analysis done by our colleague Svetonia Palmer in New Zealand. This is about a decade old, but she showed that for every 1 milligram per deciliter increase in phosphate, or 0.3 millimoles per liter increase in phosphate, that's associated with about an 18% higher risk of dying. In terms of cardiovascular death, for every unit increase in your phosphate, you have about a 10% increase in death. And there's been, again, many studies, even since this meta-analysis was done, that shows higher phosphate associated with higher mortality. But again, I emphasize the word associated. We don't actually know if it's the phosphate that's mediating this higher mortality, or if it's just a bystander that has actually nothing to do with the process. But in the nephrology community, we have certainly taken this quite seriously and told our patients that they must lower their phosphate. And in fact, the KDIGO guidelines on chronic kidney disease and mineral bone disorder say explicitly that among patients with chronic kidney disease stage 5D, those on dialysis, we suggest lowering the serum phosphate levels towards the normal range. And the normal range, as all of you know, is a concentration between 0.8 and 1.5 millimoles per liter measured pre-dialysis. So in practice, how do we achieve, so I'm just going to close my door, achieve phosphate normalization in clinical practice? The first stage, or the first element to this, is dietary restriction. The second is when feasible or when the patient is willing, intensification of dialysis. And the third, of course, are phosphate binders. But I think we have to ask ourselves, how do patients, and maybe the patients can respond to this in the dialogue, how do you feel about these interventions? Do these eat into your quality of life? Is the benefit worth all of this? I want to talk about phosphate binders because it's I guess my pet peeve, because although phosphate binders are used very widely in the dialysis population, we actually don't have any strong evidence that these improve clinical outcomes. And once again, Dr. Palmer did what's called a network meta-analysis a few years ago, including 77 randomized controlled trials involving over 12,000 patients with chronic kidney disease, almost all of whom were on dialysis. And these were trials that compared different phosphate binders to either each other or to nothing. And most of these trials were frankly designed to just see if phosphate binders could lower phosphate, and they almost all do. But the trials that were done typically had relatively short duration, only 3 months. Most trials had a very high risk of bias. And this is the 2x2 table showing the comparisons between different binders and the associations, or the effects, I should say, on mortality. And I want to just bring your attention to the bottom row here, which highlights the fact that no phosphate binder, whether it's sevelamer, lanthanum, calcium, iron-based binders, or cholestyrin, I don't think we use that very often, when compared to placebo, none of these binders has ever been shown to confer a reduction in mortality. And in a opinion piece in the American Journal of Kidney Disease a few years ago that highlighted the costs associated with phosphate binding, I'm not talking now about the cost to patients, but about the cost to the healthcare system, and the fact that phosphate binder costs are increasing at a proportion to any drug class in the dialysis patients' armamentarium of drugs. Kestenbaum and Sadi mentioned, how is it possible that in our field of nephrology, where we should be using the best evidence, how can it be that a medication class has achieved over 75% prevalence, it's probably over 80% in actuality, of use? How have we gotten to this prevalence of use without evidence of clinical benefit? We've allowed phosphate binders to enter our practice almost universally, but there's never been a trial showing that these actually benefit patients in a real way. So how do we get to this point? Well, number one, I think as I've said earlier, there's a strong belief among clinicians, and we've indoctrinated our patients to some extent, that hyperphosphatemia is toxic, and it may be, but we don't know for sure, actually. We really don't know that for sure. And I think as a result of this belief that hyperphosphatemia is associated with bad outcomes, there's been an unwillingness by clinicians to test the hypothesis that phosphate lowering improves patient outcomes. People are just unwilling or scared to actually test it. But, I could live with those first 2 points, but this is where I get a little bit annoyed at some of my colleagues in nephrology. Again, this is an editorial from our most prestigious journal, the Journal of the American Society of Nephrology, a few years ago. And the authors, I'm just taking a blurb from their article, but they say that it would be unethical. From an ethical point of view, it appears impossible to leave dialysis patients with hyperphosphatemia on placebo treatment for prolonged periods of time. And I would ask these colleagues of mine, if I could, ethical, how do we know that these phosphate binders aren't causing harm? Have you considered the patient's perspective on the invasiveness of these binders in their care? And what right do we have as clinicians to impose a therapy without having delivered the best evidence to our patients? That not just that hyperphosphatemia is associated with bad outcomes, but how can we give patients these drugs without proving that lowering phosphate actually truly improves patient outcomes? And I would argue, particularly when we look at our colleagues in cardiology, I would argue that none of the drugs that they use in common practice would have ever gotten into their practice if they didn't have good randomized trials proving the hypothesis that the drug actually improves patient outcomes. So again, I think our clinicians are kind of stuck. A lot of nephrology clinicians were stuck in the mud on this issue. Sadly, pharma has also not been an ally. Pharmaceutical companies are constantly developing new phosphate binders, and they're doing so on the premise that you must already lower phosphate. They've taken that for granted, and what they're really doing is trying to invest in products that do it better or perhaps in a safer way than the preceding binder. They're looking for Me Too products to lower phosphate, but they're really not willing or interested in proving or in confirming that phosphate binding in and of itself improves clinical outcomes. So I want to introduce the phosphate trial, which stands for Pragmatic Randomized Trial of High or Standard Phosphate Targets in End-Stage Kidney Disease. Phosphate is a multinational trial that's going to take place in Canada. It's already running in Australia and New Zealand, and the UK will be joining as well. Phosphate is an open-label, investigator-initiated, multinational pragmatic RCT comparing intensive versus liberalized serum phosphate control in patients with end-stage kidney disease receiving dialysis. And the question we really want to answer is whether intensive phosphate lowering, as compared to a liberalized strategy of phosphate control, confer a lower risk of fatal and non-fatal major adverse cardiovascular events in end-stage kidney disease patients receiving dialysis. The patients that we will be including, I think it's quite a broad patient population, individuals who are on hemodialysis or peritoneal dialysis for at least 3 months. They have to be over 45 years of age or over 18 years of age if they're diabetic, receiving 1 phosphate-lowering medication at least at the time of screening, and we'll exclude individuals who have an elective transplant that is scheduled, who are felt to have a high risk of mortality in the next 6 months, or who may be participating in an interventional trial that might otherwise affect serum phosphate concentration. The interventions, and I'll describe briefly how we're going to achieve these. In the intensive arm, we're going to be doing what the KDIGO guidelines suggest we do, namely trying to lower the serum phosphate to below 1.5. In the liberalized arm, we will discontinue all phosphate binders and only intervene with what we're going to call rescue therapy if the serum phosphate concentration exceeds 2.5. This is a broad schema of the trial. We will be randomizing patients 1-to-1 to either intensive or liberalized phosphate control, but 1,800 patients in each arm. The primary outcome, as I mentioned earlier, is a composite endpoint of cardiovascular death, non-fatal myocardial infarction, stroke, coronary revascularization, or peripheral arterial event. Secondary outcomes are individual components of the primary outcome, all-cause mortality, all-cause hospitalization, and quality of life. As I said, we're aiming for 3,600 patients worldwide, and the completion of the trial is ultimately driven by the events. We estimate we'll need about 1,200 events to be able to properly analyze the data and come to have enough power to detect about a 15% reduction in the primary outcome in the intensive arm. In terms of how we plan to do the trial, well, it's, as I said, very pragmatic. And what we mean by that is, the same way clinicians manage phosphate in everyday care, and when I say clinicians, I don't mean just physicians. It could be nurse practitioners, nurses, dietitians, pharmacists. Every center has its own policies about managing phosphate control. Whoever manages at your center in the usual context will continue to do so. The research team will not be directly involved in manipulating serum phosphate values for patients in the trial. Rather, it will be by clinicians with frequent reminders provided by the research team. All binders that are available in your jurisdiction may be used in the trial. And of course, if a patient is in the intensive arm, you can use hemodialysis intensification if the patient is willing, as well as dietary advice can be added in the intensive arm as well. We're not going to be doing extra blood work. Blood work is done quite frequently as it is in dialysis, in patients on dialysis. And so we will guide our therapy or aim to achieve our targets using only routinely collected blood work in order to guide titrations or to achieve the phosphate targets. All study visits, I should add, will be in the dialysis unit. There will be no burden on patients to come into hospital for extra visits and things like that. For the coordinators who are on the call, you'll be pleased to hear that the data collection is quite parsimonious, it's quite limited. Most of it, if not all of it, can be gleaned from the health record. And events will be centrally adjudicated. So in the intensive arm, this looks like a busy slide, but I just kind of want to highlight how we're going to do it. So Green stands for the fact that, if a patient's phosphate on their routine blood work is between 0.75 and 1.5, you're going to simply, that's great, they're in target, you're going to leave them, they're going to continue their current regimen. If their phosphate's above 1.5, the dietitian, as he or she normally would, will provide counseling about dietary phosphate restriction. That's usual care in the dialysis world. You'll ensure that the patient's dialysis regimen is optimized, meaning the patient's coming for the full duration of dialysis in order to maximize phosphate removal, for example. You'll consider dialysis intensification if the patient is interested in that. And of course, you'll consider the escalation of phosphate binding. So we have an algorithm to help guide the escalation of calcium in the jurisdictions where patients have access to sevelamer or lanthanum or other of the novel binders. Of course, those could be used as well. And if a patient becomes really hypophosphatemic, which is quite unusual, we have a strategy to de-escalate the phosphate binders as well. And this is just a table highlighting how we did this in our pilot trial that was called Target, how we can escalate the calcium carbonate dose, because calcium carbonate is still the most common binder used in Canada, how you can escalate the calcium carbonate dose to achieve your phosphate target. So we've said very explicitly that even if a patient's not in target, in other words, if their phosphate doesn't reach less than 1.5 and they're already on 3 grams per day of elemental calcium, we're not going to escalate the calcium any further. In the liberalized arm, as I mentioned earlier, we're going to discontinue all binders. And if the patient's phosphate is under 2.5, we're not going to necessarily make any change to the patient's regimen. However, if it's above 2.5, we will, at the clinician's discretion, will consider the introduction or escalation of phosphate binders in order to control the phosphate a bit better. But certainly the goal will not be to aim will be to moderate their phosphate, but not to necessarily to achieve intensive control as we would in the intensive arm of the trial. In terms of our progress to date, as many of you know, we've done a pilot RCT here in Canada called Target that demonstrated, in fact, that we were able to quite feasibly conduct the trial, implement the interventions. We found a good separation between serum phosphate concentrations between the patients in both arms. Patients were quite interested in participating. Recruitment was quite brisk, so we were quite happy about that. We've secured funding here in Canada from CIHR as well as public funders in Australia, New Zealand, and the UK. The trial is actually going to be coordinated worldwide out of the Australasian Kidney Trials Network in Brisbane, with whom we have a great relationship, and many studies and trials have been done with them over the years. And the trial is actually launched with 140 patients already randomized in Australia and New Zealand. Here in Canada, we are gearing up to go. We're aiming to recruit 1,000 participants at approximately 25 sites. Nationally, here in Canada, the trial will be coordinated out of my hospital, St. Mike's. We have our Applied Health Research Center, which is our organization that coordinates multi-center trials. We have a steering committee comprising Rita Suri, Jeff Pearl, Fabrice McQuay, Karthik Tenakor, and Swapnil Hirmath. And we have patient representatives. And of course, if any patient partners on the call who are interested, we would welcome more of you. So please reach out to me. It would be wonderful to have more patient representatives involved in this trial. Central REB has already been approved in Ontario. And I know, thank you to Rita, who's leading the efforts in Quebec. It's in progress, and I think moving forward well in Quebec as well. These are the 17 sites in Canada that have committed to participate, and I know that I've spoken to many of you who are not on this list, and I know you're working on trying to get your sites to participate. If I can't twist your arm, I know Mike will, and we really want to lower any barriers and to enable your participation. We promise to be fully supportive. Mike and I have operated in a very grassroots fashion. For those of you who've worked with me in research before, you know that I'm always accessible 24/7 on my phone to help. So with the coordinators and help with any logistic issues you might be facing, we really, really are committed to the success of this trial in Canada and worldwide. We have startup visits that will be starting soon. In fact, we hope to launch the trial at St. Mike's as well as St. Joe's Hamilton next week. And I promise, this will be a lot of fun. And most importantly, we'll be answering a question that's of vital importance to our patients. So I want to put up some questions for discussion, and then I'm going sorry, inappropriately leave the call because I have to run to the ward, and I'll let Mike handle the discussion. Would your site consider participating if you haven't signed on already? What are the logistic barriers that you face? And the patients, especially, I want to hear from the actual patients on the call. Would patients agree to be enrolled? Do you believe your colleagues, I'm speaking here to the nephrologists, agree to enroll patients as well? So these are the questions that I want, and others, of course, that come up that I'd be grateful if people can discuss. I will debrief with Mike and Alicia later on to hear your thoughts. But again, I sincerely appreciate the opportunity to present today, and very excited to finally be launching Phosphate, and look forward to working with as many of you as possible in the next few years to make a strong Canadian contribution to this important trial. Thank you very much. So Alicia, I'm gonna leave my, should I just leave this up for discussion, and then you can just kind of cancel my sharing, or should I just stop sharing?
No, I just took a screenshot, so I have those questions, so you can stop sharing.
Okay,
Amanda will put up back up our slides. We're going to take a short 5-minute break. Let everybody just stand up, get some water, do a stretch, and then we'll come back. And I see that Nancy already has a question, and we'll get to those questions, and Mike will take over at that point. So there's a little countdown here too. So yeah, have a break, and we'll be back in 5 minutes.
Hi, sir. How are you? What happened?
I like that it turned yellow when it was 1 minute or less. The little circle is yellow now. Like warning everybody, it's almost time. It also reminds me of being in a theater and going to all my musicals and all the orchestras and missing when they flicker the lights. And they to let everybody know to come back in after intermission, because I miss live theater. I think I miss live everything. Time's up. Love it. There he is. Amanda, we're going to stop sharing your screen and we're going to let Mike share his screen. As soon as he returns.
Alicia, do you want to do discussion around phosphate first, because it's kind of disconnected from some of the more general issues around
yeah, I think so. That'd be a good idea.
And so I think there's already one question from Nancy in the chat box. Nancy asks, as a patient, it'd be an interesting experience. I'm on home hemo. How will that affect your trial? That'd be great. It'll affect it by increasing the number of people participating by 1. Yay! And really the way in which the dialysis is performed is largely irrelevant to us as long as you're actually receiving a phosphate binder. So for anyone, whether they're on peritoneal or home hemo or in-facility hemo, as long as they currently have been prescribed a phosphate binder, then there's something that we can work with for the trial. And you're of interest to us because you've been given something and we're uncertain as to whether or not it's doing you good or not.
Any other comments or questions, Mike, but is there any other things you want to mention about the trial, or maybe some leading questions you have for people?
My leading question is, why did Ron put himself on service today? No, I don't have any leading questions. I think, you know, as a community, we've all been, particularly the nephrologists, have been very interested in this issue because there's a ton of uncertainty around whether or not the entire practice of controlling phosphate is actually doing anyone any good. And, you know, this is like one of the major pillars of dialysis care, is that we've been focusing a lot on laboratory values and using drugs to manipulate laboratory values. And most of the times when we've really put this to the test, it's turned out that we weren't doing very good for people. You know, we were making their numbers look better, but we weren't necessarily making people feel better or helping them live longer. And that's a real problem. And this is a paradigm shift in nephrology to tackle some of these fundamental issues that we have accepted wholeheartedly, but that we never really challenged. And our role as scientists and trialists is to try and challenge some of these fundamental beliefs and make sure that we're doing the right thing. So hopefully this will get us a lot closer to making sure that we're doing the right thing.
We do have some comments. Karthik wants to know, can you speak to the pragmatic part of this trial in relation to the recruitment for satellite sites? And does this make this approach easier or novel to use?
Yeah, so pragmatism means lots of different things. In the case of phosphate, it means that we don't have a dogmatic approach to how we change binders or prescriptions to try and achieve a goal of either getting phosphate down to below 1.5 or to higher than 2. And so that's a good thing in that it makes it easy for people to participate in the trial because they can skin that particular cat any which way they like, the ways that are acceptable to their patients and that are available to them locally in terms of drug availability, dialysis availability, any of those kinds of issues. It's also, though, the Achilles heels of trials, because when people are given a lot of freedom, they tend to make use of inertia and do nothing. And then everyone just ends up the same. And I can guarantee you that phosphate lowering in a trial will have no impact if no one actually has their phosphate lowered or raised by being in the trial. And so we need to be very vigilant. So it'll be relatively easy, I think, for patients and investigators. A lot of it can be done over the phone rather than, and through usual practice rather than very specific trial stuff. There's always a bit of a data burden element, but that's actually been, we've worked fairly hard to try and minimize it. But you will receive annoying phone calls from Ron and I about saying, you know, you have 55% of your enrolled patients out of target. What's going on? And then you'll eventually end up in the role of having one of us try and micromanage you, usually Ron, because, you know, he's that way. But it will, that's what it will come down to, because if we can't achieve a separation between the groups, then we can reliably predict that doing this entire exercise was futile. So we have to work really hard at making sure that we impact the actual values of phosphate to see whether or not it has an effect then on important outcomes like cardiovascular death and hospitalizations.
Yeah, and I think you touched on that, but there was a question too. What were some of the primary outcome measures that your guys are going to be looking at?
That's okay, Banu. You'll have lots of time when you read the protocol as you're getting involved. The major ones are cardiovascular morbidity and mortality. So it's around adjudicated cardiovascular deaths and adjudicated cardiovascular hospitalizations for non-fatal or fatal causes.
Oh, if he has another question, go ahead, Banu. But unmute yourself first.
I was just wondering if we can, so it's cardiovascular is one aspect, and there's fractures and, you know, obviously the vascular calcification piece. Would it be feasible to get some hard measures like, you know, adding fractures, maybe doing bone biopsies with, you know, pre and post, like 2 years post, if actually vascular calcification, sorry, if normal phosphorus levels are indeed helping bone remodeling and so on. I mean, that might be an area that, you know, that we can get some harder measures, because I was just thinking cardiovascular outcomes in patients, in their competing comorbidities, and phosphate alone, I'm not too sure whether it would be one of the factors that is going to play a role.
So a couple of things. So one, fractures are captured, but fractures are actually relatively uncommon compared to cardiovascular outcomes in patients who receive dialysis. So in fact, the power to detect a difference in fractures, there would have to be a massive treatment effect in order to be able to reliably detect it. And powering a trial on fractures is probably not possible. The other is that if you don't believe that you have any real impact on cardiovascular outcomes, then it kind of begs the question, why are we bothering with all the phosphate binders in the first place? Which is exactly why we need to do the trial, because we all say, oh, maybe it's not going to be a big effect on cardiovascular outcomes. And then we prescribe them to over 3/4 of our patients. Which is ostensibly to reduce cardiovascular risk. So we really need to test that hypothesis. Bone biopsies, I don't know if Fabrice is on, but Fabrice, sounds like you've got 7,200 bone biopsies to do then. Fabrice is shocked into silence anyways, if he is there. So, you know, it's just so many bone biopsies that it's definitely not pragmatic to do that on a whole trial level. I think if sites were interested and wanted to work up the extra funding for it, we would certainly be supportive. But you know, it would be a real uphill battle to try and get a lot of bone biopsies. It's an uphill battle for me to get one.
I think that might be an area where we might be interested in, to see if we can get some of that. Now, is there an easily accessible artery that can be accessed to look for vascular calcification?
I'm not the best person to ask.
Okay, thank you so much.
I see one other question from Nancy about this is the first I've heard of cardiac events related to phosphate. We usually hear about bone issues and joint pain. So this is where things get pretty complicated, I think. A lot of the issues that we talk about as part and parcel of phosphate and bone mineral disease is around hyperphosphatemia. And the degree to which we can separate them is actually probably a bit unknown. And it's one of the things that we measure in this trial is the degree to which we can separate some of these other things. And your comment, I think, is of actually great interest because we have received a lot of feedback from patients around various units in Canada over the last 5 years about you doctors are all really worried about this cardiovascular stuff and you keep talking about all of the treatments that you're doing to try and prevent it, but no one's told me about being at risk for this kind of thing. And I think it goes to show that there's a slight disconnect between what physicians are sometimes trying to accomplish and what we actually remember to communicate to our patients through our actions. And we tend to talk about the things that are causing symptoms rather than the things that we're trying to prevent from causing symptoms, I think. And so that's where part of that disconnect occurs. But I'm sure there's many other places where and reasons why that happens. Certainly, the way in which serum phosphate really gained prominence, though, was in its relationship to cardiovascular morbidity and mortality. So, and that's where much of the concentration has been over the last, well, 2 decades now.
Nancy also had a follow-up question. Wouldn't the addition of biophosphonates add to the confusion?
Oh, sorry. No, they don't really act on this this kind of pathway. So there's no real issue around bisphosphonates and the use of phosphate or calcium as a phosphate binder.
All we have for now.
Perfect. All right. Well, we'll have more opportunity for questions in a little bit too. So I'm going to attempt to share my screen. That work?
There it is.
Perfect. Sorry, I'm juggling various things. Okay, so now I'm going to talk a little bit about ACHIEVE. I'm going to talk a little bit less about the trial itself, although I'll talk a little bit about it. And I want to talk a little bit more about recruitment and the issues that we face on kind of a practical level of doing some of the trials and why it's important, and hopefully drum up some more enthusiasm. So what is ACHIEVE? Well, we just finished talking a little bit about cardiovascular health, and this is part of the reason why we think this is so important. So now this is a difficult thing to explain in anything other than a relatively cold and sterile way. So I apologize for that in advance. But one of the situation that we're faced with, the reality of dialysis is that patients die on dialysis at a much higher rate than other similarly aged people who do not require dialysis. It's roughly a 5-fold increase in the risk of death, and over half of that is due to heart-related causes. This is why I personally take heart-related deaths and disease so seriously for the dialysis patient population. And unlike the non-dialysis population, where there has been a number of significant advances in the last 20 years in the prevention and care of patients who have developed heart disease, that there's been really no therapies that we are confident do anything useful in patients who require dialysis. So we have this big problem, and we don't have any good answers to it. But we have some promise. So drugs that block the actions of a hormone called aldosterone seem to reduce scarring in the heart. And I've shown just one model here that actually is in animals, but it fairly closely replicates the kind of things that we think happen in patients who have kidney failure and are receiving dialysis. In those animals, when they're exposed to lots of salt and water and higher levels than usual of aldosterone, they develop extensive scarring, and that's all in that middle panel, and it looks deranged compared to the nice orderly grouping of heart muscle on the far left-hand panel. And when you block it with one of these drugs that inhibits aldosterone, like one called finerenone here, but there's lots of, well, not lots, there's a few others that do similar jobs, then you get a return of that orderly kind of heart structure. And that reduction in scarring is where we hypothesize that a lot of the problems actually occur. In the old days, well, no, not that old, maybe 10 years ago, we used to think that a lot of this was actually because there was an increased risk of heart attacks. But now we've come away thinking that maybe this is a different kind of thing, and maybe it's the scarring that's really important. Now, this is not a new idea. This has actually been tested several times in the past. And each one of these little dots represents a clinical trial that's been done in patients who are receiving dialysis and where they've been exposed to a drug that blocks aldosterone, or they've been in a group where it isn't. And if the dot is on the left-hand side of that vertical line that touches 1, then it means that there was benefit in terms of there was a lower chance of having a heart-related death in those who received the drug. And in general, it looks amazing. It looks like it reduced cardiac deaths by about 60%, which is larger than any effect of any drug known to humankind for preventing cardiac death. It's so good, in fact, that it is completely and utterly unrealistic to believe that is true. And the quality of many of these trials is quite low. But we have good rationale. We have some very promising but preliminary data. And if you notice at the bottom, I've written in large letters that there were 54 cardiac deaths that occurred in 1,116 patients on dialysis. That is about 1/11 of the amount of information that is actually required to be able to make a real good estimate of whether or not this has true benefit for patients. So promising, but insufficient evidence. So we've proposed and are conducting a trial that we call ACHIEVE, or the Aldosterone Blockade and for Health Improvement Evaluation in End-Stage Kidney Disease. And it asks the question is, does spironolactone, which is a very widely available drug, it was first made in about 1952, that blocks aldosterone, does it reduce heart-related deaths and hospitalizations in patients who receive dialysis? Those other trials all topped out at studying about 350 patients, but most of them was about 150 patients. ACHIEVE looks at least 2,750 patients globally for a much longer time period, so much longer exposure to the drug. The philosophy behind ACHIEVE is to try and keep things simple. What we want to do is we really want to try and reliably answer just one question. We want to know whether or not spironolactone is going to help people who receive dialysis. So we try and keep it really simple in order to help both participants actually participate and to help researchers participate as well. So we've left it as very broad eligibility. It means that it is easy to find patients who could potentially be included. And we think that's really important because we think that if spironolactone works, that it works for the vast majority of patients who are receiving dialysis. We only use local laboratory results. We don't require blood specimens to be spun and sent off to Timbuktu. And the visits are all done during routine care. So you don't have to come to the hospital or to a new location outside of where you would normally be receiving your dialysis care. And then we concentrate the researchers' efforts on what we think is most important. And that's really encouraging people to stay on drug. So you heard me say for phosphate that if we don't get people to actually have different practices around where their phosphate is, I can reliably predict that we will show no difference between strategies because they end up being the same strategy. The same thing happens with spironolactone. If one group receives placebo, so there's no spironolactone, and the other group receives spironolactone but never takes the drug, then we might as well not have done anything because no one's going to have any differences. It's like just everyone being in the same arm of the study. And then we really work hard to collect the key data on outcomes. And it's only on key outcomes. We're not collecting data on anything other than the primary question, really. And that primary question is, are we going to help people live longer and live better? So this is the trial in one slide, all of it, and a little bit about why we chose certain things. If you take a look at this, the top half of this graph before it splits off into two groups, that is all the beginning, the first 8 weeks of the study. And that's where we figure out whether or not the patients are right for the trial and the trial is right for the patients. Because if we meet that very crude criteria of that things match up okay, then everything really can resort to pretty typical standard care after that. So when we assess patients at the very beginning, it's essentially patients who are on chronic dialysis who don't have any sort of serious risk of hyperkalemia because the drug probably induces a slight increase in serum potassium. Then what happens is patients start taking the active drug. Everyone knows that they're on spironolactone. There is no control group here. And they take it to make sure that the drug is safe for that particular patient and that that particular patient will be able to tolerate it, and that after a few weeks that they will still be willing to participate. Because as you can understand, I think that anyone who has a fistful of pills to take in the morning may be, on board with the philosophy of the clinical trial at the beginning, but after 8 weeks of taking an extra pill, either something happens that they develop some intolerance or they don't like it, or they realize it's just one more pill to take and it's too much to ask. And if we were to include them for the long haul, then essentially their efforts would be for naught if they actually weren't going to take it. So we give everyone a chance to burn in and decide whether or not they still want to participate and whether or not it's safe and fair to do so. And if that's okay, then at the end of that period, they're randomized to either continuing on with 1 tablet a day of spironolactone or a matching placebo. And then things get pretty simple. We have follow-ups that are staggered every 6 months, and those are typically used for drug resupply and to ensure that no major events have happened to patients during that time. And once each year, we ask them a set of 8 questions about their quality of life, their ability to breathe, and whether or not dialysis still feels the same to them in terms of the washout period after dialysis. There's one extra visit at 3 months where, again, it's just that early on making sure that everything is going okay and that we're all on the same page. And that's it. And then we follow patients up until the last patient who is recruited has undergone about 3 years of follow-up. So it's a very long trial. These are the more formal eligibility criteria. I just put this out so that if there are any people who are interested in having their center join Achieve, that you see that this is really it. This is not a pared down list. This is just the list of eligibility criteria. You see on the left-hand side, we do restrict the age to those who are over 45 or to adults who already have diabetes, regardless of age. And that's because people under the age of 45 who don't have diabetes are at actually relatively low risk of developing heart-related complications on dialysis. Otherwise, it's mostly around hyperkalemia. The remaining eligibility criteria are ones that we put in for medical, legal, and regulatory issues, but they actually largely don't apply to patients on dialysis. So only about 1% of all dialysis patients currently already receive spironolactone or another drug in that class. And so sensitivities to it or the inability to withdraw or need to take it is very low. There is a relative unfortunate paucity of patients who are currently scheduled for living donor transplant. We're so bad at predicting life expectancy that we really don't exclude people on the basis of life expectancy unless they have an active malignancy or another medical problem of organ failure that's likely to limit their life and they're considering stopping dialysis. And the bottom one I want to draw a little bit of extra attention to, and that's enrolled in another interventional trial that tests another MRA or is likely to interact with spironolactone. So just remember that. We're going to come back to that again at the end. So where are things at with Achieve so far? So the idea for Achieve actually started in about 2013. So I'm about 7 years in on this line of inquiry. My boss, who's arguably one of the most successful cardiovascular trialists in the world, told me that if it takes less than 10 years to prove something, it probably wasn't worth proving in the first place. So I guess I'm on track. But we are likely still to try and finish this trial by 2025. We are supposed to enroll the last patient in December of 2021, but COVID happened and that has pushed our timeline back by about a year. And so expect the last patient to be recruited about the end of 2022 instead. And we will likely need to shorten our follow-up by 1 year because of that. And that will likely be okay. This will be reassessed as we get closer to the date. So importantly, where are things at so far? So in Canada, we had expected to have 20 active sites starting off in July. Canada was going to start off essentially taking the brunt of trying to figure out if the trial was really working or not and have an early lead on everyone else who was supposed to start in 2018. Then we had to push back the 2018 start for most countries because, in fact, it is inordinately difficult to do chronic drug trials with generic drugs in countries that don't manufacture that generic drug. There are about 42 different manufacturers of spironolactone globally. Many countries just have their own local drug companies that actually source this. And so importing a generic is a difficult task, as it turns out. So in Canada, we had hoped to recruit 650 patients by the end of the trial. We have currently recruited 619, and we still probably have 2 years of recruitment to go. So we'll probably meet that. Australia has a bit more of an uphill battle to do right now, but Australia actually just landed another grant late last year. And so they've expanded their number of sites by double essentially, and have restarted recruitment just recently. Uruguay also a little bit of trouble. Uruguay is a very interesting country from a dialysis provision perspective, very different from Canada, but they're slowly ticking along. And Brazil and India have very large dialysis populations, lots of people. They're also incredibly hit hard by COVID, and it has thrown a real disruption in. Unfortunately, they both started just prior to COVID landing on their borders. And the Philippines, similarly, is another very different country for the provision of dialysis, but these kinds of studies are incredibly important to them, and they have also been in major lockdowns from COVID. And we're very fortunate that Malaysia actually just started last night after a 2-year battle to get drug into their country, and Ecuador should be starting in about another week. New Zealand should also be starting just a little bit later on this year now. And they landed a grant in order to help support their sites as well. And that came in just earlier this year. And the UK landed a grant to help support their sites just earlier this year as well. And despite the fact that they're undergoing a second lockdown, we hope that they'll still be able to start in 2020. And certainly all of the regulatory movements are happening there. And we're very fortunate to have China on board. And so we've just finally been able to strike out on the regulatory procedures for China in order to get them started in early next year. But again, a country that contributes a massive number of patients to dialysis, and really important to understand that these kind of results will be just as applicable for them as they will for the rest of us. Canada is, of course, one of our major concentrations, one, because I'm Canadian, two, because this is a Canadian call. You can see here, this is all very small print, and I apologize for that, but we wanted to fit the 17 current active sites on. And you can see that the numbers of patients who have been recruited in roughly similar timelines, a couple notable exceptions, ranges from 3 or 2 to 104, so a 50-fold difference. I can tell you that Site 16 and Site 1 are basically the same size dialysis units. There is a very different way of recruiting across different centers within our country. And there's also a very different set of reasons why these kinds of things happen between different centers. Far and away, the most common reason why people say they've stopped recruiting or that they don't start is because of money. And anyone on here who has ever had to do a trial based on public funding realizes that you don't go into clinical trials because you think you're going to get rich from public funding. There's just not very much money around. And so we rely on a lot of blood, sweat, and tears in order to get this kind of work done. And our goal, though, is to try and bring the average up to 35 from 23 where it is. And that's not going to be done by taking the best recruiting centers and having them recruit a whole lot more, because they just won't have a whole lot more patients left who will be eligible for this kind of study. It's going to be largely accomplished, I think, by taking those who are in the middle group and raising their performance up by another 10 patients. So why does this happen? And this is very relevant to phosphate and to any of the trials, I think, that we discuss. So one is that we just don't have enough centers. So there's a lot of dialysis centers in Canada. They are clearly not all participating, and even some of those who are participating are not really participating. So if you're not participating, or say consider participation. And if you're considering participating in ACHIEVE, you should consider participating in phosphate and record and track and all sorts of other trials that are currently going on that happen in very similar patient populations. And that's because economies of scale really matter. Units like mine, where we recruit pretty heavily, what happens is the recruitment gets easier, patients become more a part of the culture of research, the research coordinators are down in the unit on a more regular scale, and we see big drop-offs in our ability to get people involved when we have big, long lulls in recruitment where we just don't have a presence anymore. And so the more trials and the more activity you have, the more you can actually accomplish for any of them, and the more efficient it becomes as well. because you start to develop these processes that are similar for all of the trials. What about those centers that have been participating but they haven't recruited recently? We encourage everyone to rescreen regularly. One of the sad truths of dialysis is that there's new faces in the dialysis unit all the time, and some of those people will be eligible and some will be interested. There's often we've screened our entire unit and only 2 people were interested, and that may be so. But people who weren't eligible or not interested at one point in time frequently change their mind. One of the issues around dialysis is that bad things happen frequently, and people are just not in the mindset to want to be able to do something extra at that point in time. But if you come back to them later on and show some degree of respectful persistence, then sometimes people come around, and every patient is important. So, we run into investigators who say, well, it's only going to be 1 patient. Every single patient counts. Everyone is important. They all make an important contribution getting them into the trial. And another issue has been that the importance of people's usual care providers is often underestimated. And sometimes it's overestimated. But for those patients who haven't received an endorsement in clinical trials from one of their care providers, getting that endorsement is often really important to them. And for those who say, I'm not going to approach any patient who I don't directly take care of, say that, well, then you're missing out on all sorts of people who would actually probably like the chance to participate. And you don't know until you actually go and try. We say the same thing to units where they allow their other physicians or nursing staff to decline participation on their patients' behalf, which we strongly discourage. People deserve the chance to say that they don't want to do this or they do want to do this. It's not up to us to decide. And we certainly are not good at predicting who actually wants to participate in research. Lots of questions around COVID these days. So we're very fortunate that when we built Achieve, we actually built Achieve to be able to be done under most circumstances because we wanted to be relevant globally. That meant that we allowed face-to-face encounters, telephone encounters, basically any way that you could talk to a patient, give them some drugs, and find out what had happened to them, you could make use of. And that turns out to be really important. So we can mail drugs to patients, we can phone them to make sure they got them, and then we can talk to them about what's happened to them in terms of hospitalizations and major medical problems since the last time we've seen them. And most hospitals have electronic medical records of some sort, and they're able to access whether or not things have happened, or we're able to do chart review in ways that are distant from patients. And then the last one, but we're broke. And again, no one's going to be not broke. We're all going to be broke all the time doing this kind of work. It's a matter of just trying to make ends meet and not get rich. And so economies of scale really, really do matter. Again, our unit could not recruit the way that we do if we didn't participate in a lot of stuff at once. And we mix it up. We participate in some industry work that pays better and allows us to fund some of our publicly funded work. We do a lot of publicly funded work, and we try and really make sure that we get as many patients to participate as possibly want to, because it's only through those kinds of economies of scale that I can keep everyone employed. This is the kind of trial, as is phosphate, that does not need to be done by research nursing. So one of the important things that we've stressed is that as researchers, in order to be really fiscally responsible, we need to find the most efficient ways of getting done. Sometimes that's the workflow, but sometimes that's the human resource that we employ as well. And there has been sort of a dogmatic approach in the past that everyone who is employed in clinical research needs to be a nurse. And that's just not true. The ability to delegate responsibilities depends on what the responsibility actually is that you're delegating. And most things can be done by non-clinical staff, which is really important because RNs aren't really required for their RN expertise in this. Really what it requires is conscientious people who are able to do good book work and have some human skills, and they're able to talk to patients. There's no real medical decision making. That falls back on the principal investigators and the local clinical care teams. So the last thing I wanted to mention is that, so you've seen phosphate and you've seen Achieve, and they basically apply to almost all the same patients. These are all patients who are receiving dialysis, and there's often this sentiment that you have to make a choice about which patient goes into which trial, and you have to effectively manage patients as a resource. And there is some fallacy to that as well. Co-enrollment, so enrolling the same patient in more than one study, is a perfectly acceptable practice. There is no regulatory contraindication to this. Health Canada does not prohibit the ability for patients to be involved in more than one study, including more than one interventional trial. And in fact, the minority of research ethics boards have formally stated that they would not allow co-enrollment. And I think they should all be challenged on that kind of hard-handed decision. So where much of the problem comes is from participation in industry research, where industry sponsors really don't like the enrollment of patients into another trial, and they consider that to essentially muddy the waters of how they come up with a decision about the treatment effects in their own trial, particularly because there is a perceived increased risk of having adverse events which will negatively reflect on their compound. And so the argument against co-enrollment is typically one about risk, that there is increased risk of patients when they receive more than one experimental agent. But I would point out that by the time people get a molecule to a large trial, and particularly by the time things like ACHIEVE or phosphate roll out, we already know 99% of what the adverse effects of those drugs are. You are not going to get a whole lot more information out of it. And then there's this worry that, in fact, all of these drugs are going to interact. Well, in fact, most of our patients take 9 different classes of drugs. And no one has tested whether or not any of them interact in any specific way. And when you look at half of them, they have listed interactions. We just ignore them because we already know that they're not important interactions, or they were done on the basis of biochemistry rather than whether or not they actually improve human health. So there's very little in the way of scientific validity. There's very little in the way of ensuring patient safety. And there is a lot in the way of reducing the ability of patients to maximize their contribution to advancing the science and knowledge around improving human health. So I think that you really need to stress that all of these things should be done on an individual basis. The decision for any patient to go into a trial is based on whether or not you think the trial is really right for them and whether or not it fits with their current treatment or not. And the same thing is done when you're considering a second clinical trial, is whether or not they really should be exposed to this drug, given that they might be already exposed to another drug. Most of the time, there are no real interactions that we need to worry about. If you ever question it, you should talk to the investigators who are running the trials. And in particular for phosphate and ACHIEVE, we fully support, Ron and I, as well as the international steering committees, fully support the co-enrollment of patients from these trials. And in fact, every patient who goes into phosphate is already receiving their phosphate binder, and 95% of patients in ACHIEVE are already receiving a phosphate binder. So we barely impact the differences in clinical care as it is. But there will be several other trials that will be coming out in the next several years that will involve similar patients with different agents. And for the most part, most of the things that we're involved in, we suggest that co-enrollment be considered for all of them. So the last thing I just want to say is, why is ACHIEVE important? Well, there are some trials that we do in order to try and say that we've been doing things wrong for the last 20 years. And phosphate is an example of that. And it's important because we can both reduce the medical burden on patients, we can save the taxpayers money, and we can streamline clinical care, and we might be able to get rid of some nasty side effects of one class of drugs. But it's unlikely that we're going to help people live longer, better lives by doing that. ACHIEVE is one of those opportunities where we think we have one of the most promising drug candidates out there to actually improve the lives of patients. So we're not going to just end something that was somewhat futile to do. We have the chance to actually improve people's lives. And that's really important. This is not improving biochemistry. It's not improving flow rates, none of those things. Much like Banu has said that he wants to make people feel less pain. We want to keep people out of hospital and enjoying their lives free of cardiovascular events. And that's really important. ACHIEVE also continues to push the boundaries, though, of what we can do as a community. So in the past, there's been several commentaries, particularly by prominent Canadian nephrologists, that clinical trials are just not achievable, that we can't do important work that requires an industry sponsor to be able to actually back that work. And I think that's utter nonsense. And in fact, if we don't do that, we are going to be irresponsible, and we will lose control of the way in which we actually define what's going to be important for us to do as a community. There's no doubt that long-term pharmacotherapy trials are important because most of the patients that are on dialysis or have kidney disease end up receiving drugs. And most of the most promising advances have come through drugs. And if we don't try and lead the charge on this, then we will be lost. We will not be able to actually direct what the future looks like. Achieve doesn't involve industry. I think we can do this without industry. I think we can achieve a large trial that comes up with a clear answer without an industry partner. We rely on networks of investigators and networks of funders. And this is really important because if we fail on these trials now, the next 10 years is going to look pretty dismal for trying both to get the networks re-involved and for getting funders to re-involved and trust us that we can make use of these investments to actually do the things that we claim we can do. So we need to make each one of these trials count, and we have to be very selective in what we actually choose to put all of our efforts into. And I'm clearly biased, but I clearly believe that Achieve is one of those, clearly believe phosphate is one of those. And I think it's really important that groups like CNTN think about what's going to be endorsed as being really important and where we can put our efforts, because we can't do everything. We're going to have to be a little bit choosy in order to actually do some really big, important work. With that, thank you both to the CNTN, but really in particular to the investigators across Canada and to all of the patients who have trusted us to enroll them in Achieve and come along for the ride. Happy to have some discussion and questions. I'm just opening up the chat box.
A couple already in there for you.
Nancy, you've got fingers of fire. So, okay, so are you approaching home hemodialysis units? I agree under no circumstances should someone else make patients' decisions, especially medical staff. Do people need to be identified with cardiac issues, meaning would you be amenable on meds they weren't already taking? So yes, home hemodialysis units are included. I will say though that home hemodialysis patients tend to be underrepresented in all trials because when they're at home, and we don't have as easy access to them. And so part of the economies of scale issue is trying to come up with a logistical workflow where our researchers can actually go and find patients and approach many at once rather than one at a time whenever possible. But we are working on improving both home hemo and PD enrollment in Canada. In some other places in the world, centers in Malaysia and Australia, in fact, home dialysis units are their focus. That has been where they go. I'm glad you agree about us making decisions for you. You should definitely be included in them. And do people need to be identified with cardiac issues? Nope. So our basic premise is that by having kidney failure, you're at risk for developing cardiac issues, and this treatment is hopefully going to prevent that from happening, or for those who have already developed cardiac issues, it's to prevent them from getting worse. And yes, this would mean that you go on a medication that you're not already taking, or you go on a matching dummy pill that looks and smells like it, and it smells actually quite nice, I have to say. It's peppermint. I've tried it several times myself, and you would be taking that for potentially years. Karthik asks, do you see value in a concerted effort to speak to industry about removing the co-enrollment clause? Karthik, we've entertained this. In fact, we have spoken to industry several times. And in terms of phosphate, we were actually successful in that in an upcoming industry trial that looks at anticoagulation, blood thinners, they've said, okay, no problem with co-enrolling in phosphate, but everything else is out. So I see that as a partial success. I don't see it as an utter failure, though. And part of that is because most of those industry trials actually recruit very small numbers of patients at each one of our units. So the total amount of impact that they have on us is much smaller than the impact we have on them. And I'll give the example again of the anticoagulation clinic or trial, is that in our own unit, we have somewhere north of 140 patients who have been enrolled in Achieve at various times, and it has basically removed every eligible patient for their trial from participating because they won't allow them to be in Achieve at the same time, even though there is no cogent reason why they shouldn't be allowed to take spironolactone or a placebo plus the blood thinner. Karthik, thanks, Mike. Important slide on barriers to recruitment, one that should be widely shared. Okay, I'll let you and Alicia do that.
Yeah, absolutely. We want to share this far and wide and try to, and that's kind of, you know, as you know, the whole point of CNTN is to try to, you know, network and get investigators together and start doing these important trials, and especially doing investigator-initiated trials. Like you said, I think you can do them without industry sponsorship, and I think that'd be a great thing. And Karthik has one quick question.
Yeah, just going back to that point about the co-enrollment thing, Mike. You know, one of the things I thought about is, for instance, I looked at one of the trials recently, the Fidelio DKD. You know, you look through the list of it and you see a group of Canadian investigators that are similar Canadian investigators who are participating in non-industry trials. It does make you kind of wonder. I just, you know, knowing that we all kind of are working together, you know, we work very closely together on other trials, whether when there is an industry initiative or an industry trial, that as a group we kind of get together and put out like a sort of more, you know, cohesive discussion with the main trial group around co-enrollment. Like, I just wonder if there might be more strength in doing that for some studies, you know, something just to think about. And I agree about your point about, you know, the industry trials, you know, it's only one or two, but there is that idea, and you know, maybe the patients can comment too, just about like the screening burnout as well. So there is still potentially some value in doing something like that.
Yeah. Have any of the patients on the call been involved in clinical trials before, or participated in clinical research as a participant? Feel free to just ignore the question if it's sensitive.
There. This is it, can I go? This is Nancy.
Okay, Nancy, you go ahead first.
Thank you. I have been on dialysis I'm actually a patient of 32 years. I started on PD. I was on the initial trial for twin sets back in 1988 for peritoneal dialysis. So that was a day or so ago. And actually, like I say, being a home patient, because I'm involved in CanSolve, et cetera, and have access to the kidney link, we don't hear about anything from anybody, at least not out of my clinic in Edmonton. So if we don't go looking for it, we don't find out about the clinical trials. I think the other thing that I wanted to add was that many of us, and at least from my clinic, that are at home on nocturnal are on low and slow dialysis. And so that makes me question, when we go back to Achieve, my last echo showed that, at least I understood that my heart was essentially normal, that there wasn't any major issues. And so that would bring me to the question about whether I'd be wanting to take a drug when there really isn't any issues to deal with, because I'm still on nocturnal and have been for 18 years. So
it's a good question, Nancy. And so for some patients, you know, they go, well, this is exactly why they're not interested in participating in this kind of trial. And I think that's okay. They go, you know, I'm doing quite well, and it seems unlikely that I'm going to benefit much from this. And my response to that is, you're right. Unfortunately, what I can't do is I can't differentiate someone who looks just like you and whose echo also looks really good, who is going to die next year because of heart disease. That's why we actually try and make this very broadly eligible, because things change quickly for patients on dialysis. And I'm not suggesting things at all are going to change quickly for you, but physicians have a very limited ability to be able to differentiate who's going to do well and who's not. And that's why we want to give everyone the option to say, well, I'm interested in figuring it out, or I'm not. And if we thought that there was a group of people who were much more likely to benefit than others, then we would have put that into our eligibility criteria to try and hone in on those folks who we think are the most likely to benefit and the least likely to develop any kind of side effect.
And this is the kind of...
Oh, you got muted.
Better?
Yeah, there you go.
Okay. This is the kind of information that we don't get. That again, I'm one of those simple people. I only have kidney disease. I don't have any other comorbidities. And so I'm one of the simple ones. I come in, they go, oh, look, you're on 5 meds. See you later, bye. And truthfully, I'm fine. I don't need more. That's the whole point. But we have so many others that have so many like pages of meds and multiple issues going on. And so of course, naturally they take more time. And this is where, and I would certainly volunteer to do this as a PACER researcher, but also someone really, really interested in encouraging and perhaps having more influence on getting patients involved, is a patient myself.
Well,
Especially with good background. I'm a retired OT, so I've got a medical background, PACER trained. But more than that, when you can sit down with a patient and say, yeah, I'm on dialysis too, I know what you're talking about. That's probably an aspect of that's not included in research, is that we're seen as advisors, but we're not really included in the recruitment, that we're not really included in making things happen. In many cases, I feel like we're a checkbox, and that's really frustrating.
Oh, Nancy, have we got a study for you? You're not a participant or an advisor. You are the researcher.
Hey, I'm encouraged. This is promising.
Well, so I will tell you that that is not the first time I've heard that. In fact, it's not even the first time that I have seen it in action, where we have had patients stand up and say, you should get involved in this. And we've had plenty of patients who have ended up participating in research because they saw their neighbor in the dialysis unit participating. And when they asked them if they thought it was a good idea, their neighbor says, yeah, these folks are okay, go for it. So we totally recognize the power of patients to join us, not as consultants or advisors, and certainly not as check boxes, but as active members of the research team. It is not without its hurdles, unfortunately, and you're not as common as we would like, but we're working on trying to get there.
Okay, sounds good to me.
Austin, I know you were going to talk to.
Yeah, I'm just trying to digest what Nancy said. I agree with everything she said. And my experience from being on dialysis, and I'm no longer there, but on dialysis, but I still experienced that 4 years in a clinic, and to participate in a trial or any type of research in the clinic that I was going to just didn't fit the way that the clinic was run. Really, it was not run like a place where you had an incentive to improve or do research. It was more a maintenance type of environment where you just went in and you done your 3.5 hours with your time, and the most important thing it was to keep the schedule on so that the next crew could come in and do their thing, and then they could do their thing. And I think what was lost in the whole process was any intention of doing any type of proactive care, like it was kind of like maintaining a certain standard for every patient, and the incentive for any type of research like you're speaking here was never part of any conversation. But I'm probably a different type of person, because when I was on dialysis, I collected all my data for every treatment that I took, and for my own benefit, I created a spreadsheet that tracked every lab result. But that information was important to me, but I had to struggle to actually get access to the information because it was kind of behind a closed door and you needed a key to get in there. But anyway, this is very encouraging, because if you give the patients empowerment to participate in research like you're talking about, that's a good thing. But I see is that to reach, to get out to the patient is the difficult part. I may be wrong, I don't know.
No,
But
you're certainly
that's
right.
just the way, that's the
Yeah, so getting to patients is difficult, and it's a whole lot of logistic barriers. I would say that one of the messages that I think we have a tough time communicating in an impartial way, and one of the reasons why I love being involved in clinical research is because we are not clinical care. We're actually something extra, and we're often something that's more humanizing than high volume clinical care. So we get to spend a little more time with people. We get to talk with them about trying to help them understand some of the problems that they're at risk for or have been facing. And then we get to spend a lot of time talking about one or two treatments in particular and about why these kinds of things are important, the kind of luxury that we often don't have in clinical care. And many patients find it interesting, and we feel slightly conflicted often about sharing the fact that patients who are involved in clinical trials actually seem to be better in general than patients who are not involved in clinical trials. And whether that's because healthier people tend to volunteer, or because they tend to be more proactive in their own education, or because they actually just get a little bit better care because there's just one extra layer on there, we don't know. But I think it's something that's actually really important in terms of trying to explain not just that the research is important, but that it's often a good experience for people too. It's, research can actually be quite an uplifting experience as a participant as well as for the researchers.
Yeah, I think that there's a responsibility on the part of patients to take on a more active, proactive role in finding people who are eligible and would be good subjects for such a trial, and just have if you can, have a chat with them. Most, at least a number of the patient partners on this particular call are ineligible because, such as myself and a couple of others who are here today that I know of, are ex-dialysis patients. I was 5 years on home hemo, not nocturnal, unfortunately, though it should have been. But now I'm at two and a half years into a transplant. I can still talk about dialysis, but I don't have any more experience in it. Nonetheless, that doesn't, I think, exclude me from or disqualify me from going to talk to somebody like one other patient who was on the call earlier today, who is currently still doing dialysis here in Kingston, and I will have a chat with him about this. And I think that other patient partners, when they confront people in meetings of any kind, is to, if an opportunity arises, to encourage them to participate, because it helps not only themselves, but clearly others as well. And that's one of the reasons I think many of the people became patient partners, because they want to do just that. So.
I think one of our challenges is to, to try and mass market that, to have patients reach all other patients, and so that we can really get out the message that, not only is this stuff important, but it can make you actually feel more engaged in your care and appeal to other aspects of your life.
Yeah, absolutely. And I think that CanSol was already doing that to a large degree, encouraging, certainly in an organized program, such as the transplant ambassadors. It's at a different level, but nonetheless, they are there to encourage people to pursue transplants. And I know that this has been discussed at various levels in CanSol, to do some kind of organized program that will allow for patients to more easily approach other patients, because one patient always knows more than one, to help encourage the participation in research. I certainly follow that rule, and I'm quite enthusiastic about it if I can get to talk to other people. Unfortunately, having been a home patient, I'm kind of limited. You know, I can talk to my wife, but she doesn't need it because she's not on dialysis. But I understand your point, Mike, and I agree with you entirely.
So we've got about 10 minutes left, but Banu has another question.
So Mike, I've looked at the study and I always worry about the fact that when patients go from having decent amount of urine output to becoming anuric, the chances of them becoming hyperkalemia goes up, and they're already severely dietary restricted. And giving a medication that actually doesn't help it has been a challenge. So in your recruitment phase, how many patients had to drop out because of hyperkalemia? Could you just share your experiences with that, please?
So 13% of all patients who run in drop out because of hyperkalemia in the first 7 weeks. Vast majority of that, about 85% of that, happens in the first 3 weeks, which is why the safety net is cast much more tightly in the first 3 weeks. That's all based on our pilot experience. Banu, though, I would challenge you, though, on the issue of anuria. So you say when they become anuric, they're at higher risk of becoming hyperkalemic. But by what mechanism does spironolactone cause hyperkalemia?
Well, I'm assuming it's aldosterone blockade.
That's right. And we think that that mostly happens at the level of urinary excretion. So if you can't prevent urinary excretion anymore, there's no way that spironolactone can cause the hyperkalemia. It's just the baseline risk and not the drug effect. As it turns out, that's actually untrue, though, because aldosterone acts very effectively on gut aldosterone receptors, which are upregulated during anuric renal failure. So there's always still that risk there. But we end up in this battle with ourselves as nephrologists of coming up with reasons why we think we can't do something. And in fact, it's just another big barrier that the Chief is designed so that you get a chance to test whether or not there's going to be a serious drug-induced hyperkalemia. In the safest possible condition. I guarantee you that you never start an ACE inhibitor in a patient who's receiving dialysis and then check their potassium weekly thereafter. That just doesn't happen in clinical practice. And yet ACE inhibitors increase potassium to the exact same extent as MRAs in dialysis patients, regardless of urine output. So, in fact, this is your best opportunity to try these strategies.
Actually, thanks for pointing out about the it's like, when we look back, at our hemodialysis admissions, so we looked at about 100 people who were admitted, and a fifth of them were due to hyperkalemia. So it is actually quite a driving force. And that's why
that's their baseline risk, though. That's non-drug amenable hyperkalemia. About 40% of all individuals on dialysis should have potassium greater than 6 at least once per year.
And are you joining hands with one of the new potassium binding companies to see that if we can somehow offer them that medication so that we can prolong their time on the medication?
Well, we'd love to join pocketbooks with them and take all of their money, but they said that we're small potatoes for them, and they don't think that they need to demonstrate further benefits of potassium lowering in order to sell copious amounts of drug. So we parted ways.
Thank you.
Awesome. I think that's all the questions we have. I'm going to I just asked Amanda to share the last slide that has some of our, the website, Twitter, my email. If there's any way you want to have any questions about any of this, I can put you in touch with people. You can join one of our committees. You can present at our next meeting, because we definitely want to make these a more regular thing, especially since we probably will not be meeting in person for at least another year. So yeah, I'd just like to say, is there any parting words either from Hans or Karthik?
Just to say, really fantastic talk. It was really nice to hear from all the speakers today. And I think what I love the most about these types of meetings is we went from, studies that are in their early phase of design, gauging questions about how to make things better, really speaking to patient partners about how practical, pragmatic these things are, to studies where protocols have been developed and they're about to sort of start launching. to international studies that are already established, talking about how to maximize recruitment. So this is really the value that we have with these types of meetings. I was really, really taken up by the patient comments and conversation today. I think it was quite helpful. And one of the things I spoke to Alicia about is afterward, I think these questions that the investigators are posing, sometimes, this isn't the great forum for everybody to provide answers or feedback just because time isn't there. So I've asked Alicia if she can send sort of the questions out, and as people have time, especially our patient partners, if they have time to respond back, that would be fantastic. But this has been really, really good. It's hard to sit in one spot for 3 hours, but I can tell you I did it with a lot of success today. So thanks everyone for their participation.
Yeah, I would echo some of that. And it was a well-attended conference or symposium. We had up to 40 people at one point. We're only a few of them have left. But the discussion was great. I think we've accomplished something. So thank you all for coming.
Thanks, everyone. We're going to, Ron has given me permission to send out his phosphate slides. As Karthik said, I'm going to send out some of the questions that came out of this for people in case in their retrospect they have some other comments we can pass along to the researchers. And so, yeah, thank you everybody for taking this time out of your day to sit in front of a screen and listen to some more talking. Take care, everyone, and we look forward to seeing you at our next one. Bye.
Bye.
Take care, everyone. Thank you.